You'll be there for the USCAP, Dr. Garcia?
I will you be there?
Yes.
Oh,
What about you, Paromita?
Yes, I'll be there too.
Okay,
It's a
great.
long
And
post-COVID
anyone-
gap, so I'm looking forward to it.
Great.
Yeah. Dr. Annie, I think we can start.
Okay, sir. Okay, sir.
Okay, right?
Yes, sir. So, good evening, everyone, and good morning to you, sir. Welcome back to our second day webinar on head and neck pathology. Following yesterday's insightful presentation on head and neck pathology by the actual experts in their domains, we promise you yet another lively session. Let's start first talk of the day. It is my pleasure to welcome Dr. Anila K.R., Associate Professor, Regional Cancer Center, Thiruvananthapuram, to introduce the speaker. Madam's fields of interest include head and neck pathology, along with breast and endocrine tumors. Madam is also our moderator for the slide seminar session for the upcoming 90th IAPM chapter meeting. Over to you, ma'am.
Yeah. Thank you, Dr. Annie. So before introducing the speaker, I would like to just brief on the today's significance of today's topic. So the 2022, the 5th edition of the WHO classification of tumors of head and neck is going to be out. So there are significant changes like the classification realignment. So we have like separate chapters dedicated to individual entities, taking into consideration that there is no overlap of the different entities. For example, we all know that the Sino-nasal has the salivary gland tissue, larynx has salivary gland tissue, but under them we don't now extensively discuss. They are all grouped under the salivary gland chapter so that there is no overlap or repetition. So that is one nice change that I have noticed. And also you have different chapters for soft tissue, melanocytic tumors, hematopoietic tumors, and so forth. And there is a new chapter devoted to neuroendocrine neoplasms and paraganglioma. So that is also very welcoming. And apart from that, we have essential and desirable criteria for all the entities. So that as for pathologists, that is also really helpful because we should look for at least the essential criteria when we are diagnosing a particular entity. And then comes the new entities and the emerging entities. So new entities are those wherein in the previous edition, that is the 2017 4th edition, they were provisional entities. But because of the build-up of data now, they have been included as established newer entities. So about the emerging entities, still data is to build up so that maybe after 5 years when the new WHO comes in, they will be included as newer entities. So today's topic is on these emerging entities in head and neck pathology. And we have an eminent speaker, Joaquín J. Garcia, Dr. Joaquín J. Garcia. So if I go on to introduce him with all his credentials, then we'll lose a lot of time because those are extensive. So I will just briefly introduce him. And first of all, I'll tell that I'm privileged that I was able to do observership under him. So Dr. Joaquín J. Garcia pursued undergraduate studies in molecular and cell biology at the University of California, Berkeley, and attended medical school at Stanford University School of Medicine. Dr. Garcia trained in anatomic pathology at University of California, San Francisco. He did his oncologic and molecular pathology training at Memorial Sloan Kettering Cancer Center, head and neck pathology at University of Pittsburgh, and he is a professor of laboratory medicine and pathology and has a joint appointment in the Department of Clinical Anatomy at Mayo Clinic, Alix School of Medicine. His areas of expertise are in head and neck, frozen section, and molecular pathology. He has published over 100 peer-reviewed manuscripts and authored several book chapters and books. Dr. Garcia is currently the chair of anatomic pathology and the digital pathology program at Mayo Clinic, Rochester. So, Dr. Garcia, a very good morning to you. And on behalf of the Kerala chapter, because I know it's very early morning there, and on behalf of Kerala chapter of IAPM, I take this opportunity to thank you for accepting to be part of this webinar at such a short notice. So, over to you, Dr. Garcia.
Good morning, good evening, depending where you are. Thank you for the incredibly pleasant introduction. Really appreciate it, Dr. Anil, and of course, I enjoyed the time I had with you when you were here. What a pleasure and a privilege to be invited here today, talk about something really exciting. We're talking about emerging entities in head and neck pathology. I know I have some talented people on the line who are familiar with some of these entities. We're gonna just talk about a few of them, not all.
Yes, it's visible, sir.
Excuse me? Okay. Can everyone hear me and see my screen? Can someone confirm that, please?
Yes, sir. Yes, sir.
Yes.
Okay, excellent. Yeah, so we're going to be talking about emerging entities in head and neck pathology, and as Dr. O'Neill mentioned, what used to be suspicious and new is now an established entity. Distinct names are coming about. In head and neck pathology, we see names expand and collapse all the time. Sometimes they expire, then they come back. Like the OKC, the odontogenic keratocystics. It went away and then the name came back. We'll see something similar with mucinous adenocarcinomas of the salivary glands. So as we talk about our emerging entities, we're going to focus on the sinonasal tract and the salivary glands. Of course, we could go all day if we wanted to talk about the oral cavity and the larynx and thyroid, bone and soft tissue, but we're gonna make our home there. Here are two subdivisions, and we'll start with salivary. The objectives for today, by the way, this is my colleague, Dr. Melanie Boyce. She is a pulmonary and cardiac pathologist here at Mayo Clinic. She is using obviously both digitally scanned images as well as glass slides. Over the next few slides, I'll tell you about the digital pathology program at Mayo Clinic. The objectives of today, we have a few, are to recognize reclassified and new entities, distinguish benign and from malignant entities, because sometimes we can have overlap, effectively apply ancillary studies. This is incredibly important. Not only do we want to save money, but we don't want to congest our laboratories. If your experience is anything similar to the histology laboratories in the United States, we are simply short technicians, so we're trying to apply more diligence and utilization management strategies when it comes to applying immunistic chemistry, in situ hybridization, and so forth. We also want to understand general treatment pathways. There'll be some overlap in the way these tumors look morphologically, immunophenotypically, but their treatment may differ. And this will be particularly true in the sinonasal tract. And that'll be important for you to understand as you make distinctions for your patients. Of course, as you get to that point, you'll be able to enhance your pathologist to clinician communication. I think this is the most important thing. More important than the diagnosis and the comment and the signature and the adjective is, are you conveying your message to your clinical colleague? And of course, if we can do that, we can optimize oncologic care. So that's where we're headed. Another slide here, H&E slide, it's a glass slide. So currently I'll tell you real quickly about the digital pathology program. Our digital pathology program is a 6-year program. We're entering our 5th year. In 2023, we will be scanning just short of 3 million slides per year in the Mayo Clinic enterprise. That spans Arizona, Florida, Rochester, and our health system, which is a few hospitals in the Midwestern United States. Let's talk about emerging entities in head and neck pathology, specifically in salivary glands. I told you we would start with salivary. Here we are. And in the practice of salivary gland pathology, as you know, or as you will learn, let's start with the upper left. These cases are extremely challenging. for a lot of reasons. We're going to see a couple of those reasons now, but one is you don't see them that often. Unless you were at a cancer center, maybe you have a robust head and neck service or ENT surgical service, you'll see a lot of salivary gland tumors. Maybe you have a consult practice or you're a reference lab, you'll see a lot of these tumors. At Mayo Clinic here in Rochester, we're a reference lab, so we get probably about 7 or 8 salivary gland tumors per day. And then internally we get 1 or 2. At Mayo Clinic Rochester, we operate on about 250 salivary gland tumors per year. Uncommon overall, similar to that landline phone there. Don't see those too often either. Heterogeneity. We'll give you a couple examples of how the same tumor, for example, mucoepidermal carcinoma, can look incredibly different from one subtype to the next, from one variant to the next. And I'm sure you're familiar with that phenomenon. Molecular, as you know, is also becoming more prominent. We understand genetic rearrangements and their frequency in salivary gland tumors. It was just a couple of decades ago when it was exciting to find a fusion transcript in salivary gland neoplasia. Now it's commonplace. We'll see a few new ones at USCAP in New Orleans. So that requires persons such as yourself, savvy diagnosticians and academicians to keep up with this molecular freeway. We'll talk about that in a second too. We're going to talk about 3 tumors specifically for emerging salivary gland tumors. Intraductal carcinoma, you've heard about this. This has been around for a while. Its name has changed, but our understanding has improved. Mucinous adenocarcinoma, the name has gone all over the place. There's multiple names. We're settling in on this one for at least a subset. Microsecretory adenocarcinoma, relatively new one, also associated with genetic rearrangements. And what we're seeing, putting all this together, is a frequency by which you will sign out a case as adenocarcinoma NOS, not otherwise specified, is going to get smaller and smaller. And that's good. We'll find the same phenomenon when we get to sino-nasal tract. And SNUC, we'll find that SNUC is decreasing as well over time, as many of you are aware. I mentioned one of the challenges underpinning salivary gland neoplasia and diagnostic surgical pathology is this rapidly changing molecular and cytogenetic landscape that's associated with this tumor and that tumor at this frequency, at that frequency. But it's also in this tumor, if it's this subtype, very confusing, right? Just a decade ago, we would find 1 or 2 FISH tests that we could apply. And sometimes we use those with discretion, but oftentimes it makes sense to do NGS. We don't do it super frequently, but occasionally we do. Especially if you find that NOS category where you can't find a bucket to put it into. And the reason we're moving towards NGS versus FISH is because of this genetic complexity and the overlap. Let's walk through a couple of these. You're gonna see pictures of actinic cell carcinoma and adenoid cystic. You'll see EMCA and intraductal carcinoma, mucoep and mucinous. You'll see pictures of those today. I put on some of their associated rearrangements and of course their frequency. There's only a few that are effectively diagnostic. You can point to the rearrangements of NR4A3 in the actinic cell. You could point to salivary duct carcinoma, some of its findings, although heterogeneous, mucoepidermoid carcinoma, clear cell carcinoma. But many of these genetic rearrangements hover around 60% or lower, making it more challenging. If we're going to talk about salivary glands, we have a quick review to do of the major salivary glands. Take a look at that parotid gland on the left there. You can see both the deep lobe and the superficial lobe. Superficial lobe is reflected and hanging just on top of the ear there. You can see the facial nerve coursing through that parotid gland between the superficial and the dope lobe, the deep lobe. Just an incredibly nice section there. 80% of the parotid gland is superficial lobe, 20% is deep. Of course, so even those terms are they're artificial. We use them mostly for a landmark for a facial nerve. Most of our tumors are going to be in the superficial lobe, of course, because most of your real estate is there. But it's important for us to be cognizant of adjacent structures like that facial nerve and some of the arteries and the deep lobe. Even when you have a superficial lobe tumor, the size of that tumor, classification of that tumor, and to that end, the biology of that tumor in the superficial lobe will determine if they take the deep lobe. So, important to pay attention. In the submandibular gland, you have two of those as well. Look in the middle, and you can see one of those submandibular glands just beneath the mandible there, just inferior to the mandible. Parotid gland tumors, about 20% are malignant. Submandibular tumors, 40% are malignant. When we get to the sublingual glands, they're on the right. About 80% of our salivary gland tumors are malignant. So real estate is actually important. When a surgical colleague gives you a specimen, they say, hey, this is a neck tumor, this is in the face, and you can tell it's salivary gland. It's nice to know if you're dealing with a parotid or submandibular. So if you can't figure that out with the background histology, you may want to look into that operating report or inquire with your surgical colleague. Salivary gland tumors are also difficult in the gross room because of their overlap. We're going to go through one example of what I regard as the 9 classic gross presentations of salivary gland tumors. You can, of course, have an encapsulated tumor like you see here on the left. This is a nice pleomorphic adenoma. You see that capsule best around 6 o'clock, maybe 5 o'clock to 7 o'clock, that thick white capsule. You can see that in pleomorphic adenoma naturally, but you can see it in malignant tumors as well, such as a carcinoma ex pleomorphic adenoma. This middle gross pic has a circumscribed tumor, not encapsulated, but circumscribed. We see this in, say, a basal adenoma, a basal adenocarcinoma, or a sphenic cell carcinoma. So circumscription can also be seen in malignant tumors. Look at the nodularity on right. On the right, you see that almost mahogany brown looking tumor, and you on the line are probably thinking, I bet that's an oncocytoma. And you're right, it's an oncocytoma. That nodular growth pattern can be seen in oncocytomas. It can also be seen in oncocytic carcinomas. On the left, there we go. Now we feel.
Dr. Garcia, sorry for interrupting, but is it possible to use a pointer? There are some requests.
Yes, absolutely. I apologize.
Yeah, thank you.
I apologize. I want to go back a little bit. Okay, parotid gland. This is your facial nerve right there. Whoops. This is your facial nerve. Can you guys see that? Perfect. Can you guys see that? Can you see my pointer?
Yes, sir. Yes,
we
sir.
can see.
Yes.
Right.
Yes.
I was talking about this facial nerve. This is a superficial lobe. This is the deep lobe. Here's the submandibular gland right here. In the sublingual gland, you have 2 of all your major salivary glands. And in this cut, this midline cut of the mandible, you can see 2 sublingual glands. This is the encapsulated tumor. You can see that capsule around 5 to 7 o'clock. Here's a circumscribed tumor, not encapsulated. And here's that nodular growth pattern. What I'm really trying to show here is that you can see overlapping gross growth patterns in benign and malignant lesions. This is a little more easy, right? This white tumor looks to be entrapping fat, so we're a little more confident that this is an infiltrative tumor, a malignant tumor. Moving to the middle, that chondroid, glistening, glassy appearance that we like to see to reassure us that we're working with the pleomorphic adenoma. That's great. Of course, you have to be diligent and make sure you don't have anything malignant in there. And if you do, if you have something malignant in there, you want to be able to call it. Is it an adenoid cystic carcinoma, a salivary duct carcinoma? Salivary duct represents 40% of the malignancies in carcinoma XPA. You want to be able to call out the type of neoplasm, if relevant, the grade of that neoplasm, because that'll determine how they get treated. For example, if you say there's adenoid cystic carcinoma growing in a carcinoma XPA, then they're going to get radiation. If you say mucoepidermoid carcinoma, they might get away just with surgery. I talked to you about a oncocytoma earlier in that nodular growth pattern. Look at this mahogany brown here, that central scar. Okay, so another adjective we can apply grossly, oncocytic. 3 more here. 3 more, we have a hemorrhagic tumor, we have a cystic tumor, and a necrotic tumor. Turns out, this one on the right, this necrotic tumor, this is benign. This is actually a myeloepithelioma. It looks the worst to me. This is also benign here, this basal adenoma, this cystic tumor here. Salivary gland pathology is also difficult because of the histologic variants that exist within a given tumor type. For example, mucoepidermoid carcinoma. These are 3 examples of mucoepidermoid carcinoma, 3 different subtypes. There's over half a dozen subtypes. I just put 3 to underpin my point. On the left, we see clear cell mucoepidermoid carcinoma. Wow, this looks more like clear cell carcinoma than mucoepidermoid carcinoma. Okay. Same thing with actinic cell carcinoma. Actinic cell carcinoma can also be clear. Tough. That could be tough. Oncocytic mucoepidermoid carcinoma can look very similar to an oncocytoma, an oncocytic carcinoma, an oncocytic actinic cell carcinoma. Again, that overlap. We have to, as pathologists, be aware of those subtypes and then the subtypes of the other types, so we can perform appropriate testing. Of course, share cases. You'll probably share a lot of cases of salivary gland pathology. We do here at Mayo Clinic. At least a third, 40% of our salivary gland tumors end up getting shared from the consult practice. The last variant of mucoepidermoid carcinoma I share with you is the sclerosing variant. Look at that nice sclerotic background. Okay, these glands don't too remarkable, but of course, if you look closely, you can see some mucus cells start to gather up, start to stack up. So you'll start to ask questions about malignancy. On the left, we're going to talk about actinic cell carcinoma, and actinic cell carcinoma has multiple subtypes as well. There's actinic cell carcinoma is one of those tumors that isn't comprised of just one cell type, such as a myoepithelioma or a oncocytoma, or not an oncocytoma, but maybe a myoepithelial carcinoma. Those can be one cell type. Clear cell carcinoma can be one cell type. Actinic cell carcinoma can be up to 4 or 5 different cells in there. Granular cells, vacuolated cells, clear cells, intercalated cells. Hence, we get a lot of morphologies, a lot of subtypes. Look at the left here. This was in a cystic tumor. You can see this nice papillae stretching out into the area of focus. And if you look at the line, and just so you know, all these will be made available to you. These PDF will be made available to you, be able to see all these. And when you look at this lining, you'll be able to see these tall columnar cells with basal nuclei in that granular cytoplasm superficially. Here in the middle, this is an example of actinic cell carcinoma. It's a little more clear in its cytoplasm. If you get in closer, you might be more suspicious. Think this is a little granular, this is a little grungy. It's pink though. Certainly looks different than what's on the left. Lastly, actinic cell carcinoma on the right. You see it's well circumscribed. On the left, you have some collagenous tissue pushing against it. If you look into the tumor here, you can see all those different cell types I mentioned, the granular cells, the vacuolated cells, the clear cells. But the reason I showed this is because of what's in the center. This is called a TALP, a tumor-associated lymphoid proliferation. But TALPs aren't specific to actinic cell carcinoma. You can also see them in mucoepidermoid carcinoma, lymphoepithelial carcinoma, lymphadenoma. Lots of overlap in the variants. One more example. I want to show you EMCA, epithelial myoepithelial carcinoma. Look at these 3 subtypes. They're easy to distinguish from one another, but they might be difficult to distinguish from other tumors. For example, this spindled EMCA on the left here, it might be difficult to gather that there are even ducts there. They may just look like myoepithelial cells to some people, and I could understand why. They might look like they're not biphasic, that they're monophasic. I can see why. If you're not thinking about that, you might not think to get a P40 or P60, P63 to declare that biphasic pattern and then say, okay, I have a biphasic malignant tumor. I need to think of epithelial myopithelial carcinoma, basal cell carcinoma, adenoid cystic carcinoma. Look in the middle here. This is also EMCA, this cribriform pattern. I just remember when cribriform pattern was associated with adenoid cystic carcinoma, and everything has changed since then. And you can see it in basal cell adenoma, basal adenocarcinoma, obviously epithelial myopithelial carcinoma, several tumors. So we try and take that cribriform architecture in context. Is it the predominant pattern? Is it the predominant feature? Or is it just kind of focal? And is it discrete? Look to the right. Epithelial myopithelial carcinoma, apocrine subtype. You can see how this may be confused with another apocrine salivary gland tumor, like a subset of salivary carcinoma. So the subsets, the variants of these tumors in epithelial myopithelial carcinoma can cause diagnostic challenge. Let's get into our tumors. Let's get into our emerging tumors. We're going to start with intraductal carcinoma. Again, we're going to talk about 3 today. And it's these 3 tumors that are helping to contribute to chipping away at that bucket of adenocarcinoma NOS. Intraductal carcinoma, this is really nice. Sometimes these are well circumscribed, sometimes infiltrative. Here you can see some slight infiltration taking place in the center of that micrograph. What do we see? Cystic glands, microcystic glands, some solid nests. Looks like a relatively low to intermediate grade pattern there. To the left, I told you they can be well circumscribed, or to the right, they can be infiltrative. Distinct glands. We can see the cytology picking up a little bit on the right with the nuclei, nucleoli picking up just a little bit. Hard to tell just looking at this H&E. Is this a monophasic tumor, a biphasic tumor, a triphasic tumor? And this is important diagnostically. If you can determine that a tumor is monophasic, then your WHO classification menu just shrunk down to about 3 or, well, malignancies, just 4 or 5 tumors. If it's biphasic, you're probably down to half a dozen tumors. So important distinction for us. You might need immunohistochemistry to figure that out here. Let's take a closer look at this intraductal carcinoma. A vague cribriform pattern here, maybe a little less discrete, less refined than what we see in adenoid cystic, but still somewhat of a mimic. Very delicate tumor cells. You can see papillae often fall off, and you can see not only cellular heterogeneity, but also architectural heterogeneity within the same field. This was in a cystic case of intraductal carcinoma. It was mostly cyst, and this is just popping into the lumen. You can see columnar cells, little apical hobnailing. Pretty monotonous cytology, though. Not too ugly there. Let's look at this case on the right. On the right, ciliated tumor cells. Wow, that's spectacular. Again, we didn't think that these tumors used to ciliate back in the day, but they do. We see salivary gland tumors that ciliate. We've seen this in mucoepidermoid carcinoma as well. Important immunohistochemistry for intraductal carcinoma. Not uncommon for people to get a keratin. In that keratin, if you look at there on the left, it's difficult to determine if you have a monophasic or biphasic tumor. You probably have to go to the right where you see that P63. And that P63 helps you determine that you have a biphasic tumor. In the middle, the S100 isn't too valuable, but it's important to note that it can be positive and diffusely positive, usually on the weak or moderate side, but that can be seen in other tumors as well, like secretory carcinoma, for example, a 12-15 translocation associated tumor. Importantly, intraductal carcinoma is typically androgen receptor negative. That's what this stands for, AR is androgen receptor. And that does have an exception. That is the apricot variant or subtype of intraductal carcinoma. So of course, it's always an exception. Some take-home points about intraductal carcinoma. Formerly known as low-grade salivary duct carcinoma and cribriform cyst adenocarcinoma. I think we've moved away from those names. I hope we have. Typically in adults, usually in the range of 60 years of age, overwhelmingly in the parotid gland, rare in the others. Excellent prognosis. That is a typical course. Of course, in salivary gland tumors, you can always have the potential for high-grade transformation where a low to intermediate grade tumor takes off. An intraductal carcinoma can show that. It can show stromal invasion. There are multiple subtypes: intercalated duct, oncocytic, apocrine, and mixed subtypes. We'll keep our eye on apocrine. Apocrine in general in salivary gland tumors, keep your eye on, get nervous. They can often be locally aggressive and recur and potentially involve nodes. And they can often serve as histologic mimics to cutaneous adnexal tumors as well, if in the right location. These subtypes have genetic rearrangements associated with them. They're not necessarily specific, but they're frequently seen. And that apricot subtype, most commonly associated with invasion. Again, we'll keep our eye on African morphology in general for salivary gland tumors. I think we have a question, but I was gonna finish the talk and then take questions. Is that reasonable?
Yeah, Dr. Garcia, we'll have all the questions at the end.
Perfect. I'll keep going.
Once you
Thank you.
finish. Yeah.
Let's go to mucinous adenocarcinoma, another emerging entity. This one, like a lot of mucinous adenocarcinomas, insert anatomic site here. You can see this in the colon. You can see this in the GYN tract. This tumor with this swath of background mucin, little papillae and micropapillae, and nests just floating in that mucin. My good friend and colleague Justin Bishop shared me this picture on the left, showing that tumor actually approaching skin. Okay, so skin up here, this dark red character on the left, and on the right, we see a little papillary pattern of this mucinous adenocarcinoma. Tremendous heterogeneity. Let's go a little deeper. In the middle, you see more spindled cells, maybe. On the left, a little more clear. On the right, a little more epithelioid. These can be high grade. They can be mucin poor. And when it comes to immunohistochemistry, there's really not much to work with. Of course, you want to make sure you don't have a MET on your hands. So inquire about that possibility, but these are typically CK7 positive and CK20 negative. Take-home points on mucinous adenocarcinoma. Similar to intraductal carcinoma, it has some old school names that we're trying to get rid of, like colloid carcinoma, signet ring carcinoma, intestinal adenocarcinoma, and mucinous cyst adenocarcinoma. Typically in adults, mostly minor salivary gland sites, and that means usually oral cavity. Prognosis is excellent. These patients are mostly treated with surgery. In 2005, the WHO showed cyst adenocarcinoma and mucinous adenocarcinoma to be distinct entities, but in 2017, they were actually lumped together and placed in that adeno-NOS category. I told you that adeno-NOS category is shrinking similar to the fashion that the SNP category is shrinking in sinonasal pathology. Mucinous adenocarcinoma today in the present state is its own entity, and there are subtypes: papillary, colloid, signet ring, and mixed. No known clinical import to date on those, so we don't report them, but necessary to be mindful of. Let's move on to our third emerging salivary gland tumor, microsecretory adenocarcinoma. This is a challenging one. It can take you all over the place. It could take you into mucoepidermoid carcinoma. Maybe you end up at adenocarcinoma, NOS. Maybe you think about adenoid cystic carcinoma. Just a real tough one. And this is also a tumor that's had a variety of names, but it's recent insights that has gotten us to where we are and giving this its own name. Similar to introductive carcinoma, this can be well circumscribed, as you see on the left, or infiltrative, as you see on the right, as it jumps around bands of skeletal muscle. Little higher power on the cytology of the microsecondary adenocarcinoma. Again, very understandable why this was formerly, or even in the future, called adenoid cystic carcinoma. Distinct glands, very thin, attenuated epithelium. You don't often see mucus, but you can, just like in any other salivary gland tumor, you can get some metaplasia. That material in the lumen is often reminiscent of adenoid cystic carcinoma. It can be confusing, as I've mentioned a couple of times. From an immunophenotype standpoint, microsecondary adenocarcinoma, usually P63 positive, P40 negative, SOX10 positive. It's similar to secondary carcinoma, where in the beginning there was a fair amount of cytogenetic issues and immunochemistry, but I think people are becoming more comfortable with that diagnosis. Something similar will probably happen with microsecondary carcinoma. It has a relatively distinct look. Now that we know it's distinct, it just took us a time to get there. Seen in adults, usually around 50 years of age. Again, oral cavity, excellent prognosis. And that's typically how it goes. There is a translocation that we keep our eyes on. Again, another reason for that NGS testing, that panel testing. This could be seen, this tumor, this microsecondary adenocarcinoma, would be seen in the differential of mucoep or the differential of adenoid cystic. If you work by cytogenetics, those fish assays are entirely different and not informative to one another. Not entirely. So NGS testing probably becoming more and more common. In the present state, this is a distinct entity. Take-home points for emerging salivary gland tumors: gross and histologic overlap common, genetic rearrangements even more common, and novel entities are coming about. So keep your eye on those. Dr. O'Neill mentioned that. Let's transition into sino-nasal pathology. And when we go into sino-nasal pathology, let's start with the practice. Some of the same challenges we spoke of earlier. We don't see them a lot, they're uncommon, there's overlap, there's heterogeneity, and now molecular findings as well. The tumors we're going to talk about today, and some are more maybe evolving than emerging. They're not entirely new. You've heard about them for a couple of decades, but there's new insights. We're going to talk about SNUC. As NOS of the salivary glands contracted, so does SNUC of the sinonasal tumors. We'll then move on to nut carcinomas. This complex, sweet sniff complex deficient, and HPV-related multiphenotypic sinonasal carcinoma. Let's see, what do we have here? Histologic overlap, what a surprise. I have to warn you, you won't have this in your PDF, but this is actually, on the left, this is not cholangioparasitoma, this is a case of rhabdomyosarcoma. It's just mislabeled, but you won't get that when you get the PDF. So we have a rhabdomyosarcoma on the left, we have a biphenotypic sinonasal sarcoma in the middle, and a melanoma on the right. These are all sinonasal malignancies that they're all malignant, they're all high grade, they can all be spindled, they can all be epithelioid, they can all have some oncocytic areas. So similar to that theme that we saw in the salivary gland tumors, the sinonasal tract can give us some overlap that's troublesome. SNUC. Sino-nasal undifferentiated tumor. This tumor was labeled by Frierson back in, it was 1984. And it was a clinical pathologic entity to represent not only a high-grade malignancy that you couldn't put into any distinct pathologic category, but it had a clinical course that was distinct. There were large masses, destructive, crossing midline, and the patients would rarely make it past 2 years. But that was often as good as the description we had. And of course, we've been able to tease that apart as we become better at finding rhabdomyosarcoma, for example, sinonasal melanoma, INI1 deficient carcinomas, HPV related tumors, and so forth. Higher power on these SNUCs, this is what we would expect to see. High-grade morphology, high-grade atypia, vesicular chromatin, prominent nucleoli, brisk mitotic activity, necrosis, angiolymphatic invasion, just not uncommon. But where do we put all of these tumors? They can't all be the same, and that's kind of what we get to. So the SNUC, in its original intent, because we're not there now, SNUC has become a dirty diagnosis. It's a big wastebasket. It was originally intended to lack morphologic and or immunophenotypic differentiation. Squamous immunophenotype, a rare exception. Okay. Lack squamous and glandular features. And as I mentioned, they would carry a poor prognosis. Since 1986, Frierson would be disappointed. The term SNUC has been loosely applied to oftentimes just an unclassifiable keratin positive malignancy of the sinonasal tract. I'm probably guilty. I'm not pointing my finger at anybody other than myself. About nut carcinomas. Again, nut carcinoma is not particularly new, but we do have some new insights. These are high-grade tumors. They're typically midline, although not invariably. Typically lethal, although not invariably. And not uncommonly, we'll see these large nests pushing or infiltrative architectural patterns. Higher power here, that high-grade basaloid morphology. We can see brisk mitotic activity again, and then notoriously that abrupt squamous differentiation we see in these tumors, whether they be head and neck or in the thoracic tract. Little necrosis there on the right as well, adjacent to that squamous differentiation. Now for nut, you're probably aware of this. You can get a P40 stain. Your nut immunostain, of course, will be positive. You see one in the intermediate power in the middle. And then on the right, you see that nut immunostain at a higher power. And this is not uncommon, that granular speckled pattern we often see. %50 of these cases are located in the head and neck. And when you're in the head and neck with nut carcinoma, 50% of them are sinonasal. They're rare, but not recognized with a high enough frequency. So they're probably not as rare as we think, similar to some of these other sinonasal tract tumors. They can be seen anything from children to adults, less than 10 or over 80. Often seen in non-smokers, and as you probably know, common fusion partners include NUT and BERD4, although there are other fusion partners. These are just the most common. Prognosis, poor. These are frequently chemo-resistant tumors by way of that pathway. Our last, I think it's our last, no, our second to last, sinonasal tract emerging entity. You're probably familiar with this one. This one's been around maybe just under a decade, maybe. Now, as we sniff complex deficient sinonasal carcinomas will often look like this. They can look high grade, but have a monotonous cytology to it. They can be in cords, sheets, trabeculae, often have this reactive background. higher power on these tumors. On the right, you can appreciate that monotony, that cellular monotony, that often should tip your cap that you're dealing with a potential INI1 deficient tumor. Architectural pattern nice on the left. A little higher power on this INI deficient sino-nasal carcinoma. Again, appreciate that monotony, the uniformity. Sometimes cytoplasm can be scant, or it can be a little more voluminous and be pink or clear, like you see here on the right. Moving through the IHC on this tumor, universally, you'll find a good keratin being uniformly positive. And of course, as you'd anticipate, that INI1 immunostain will be negative. You have an internal control on the left. We're in the middle picture here. On the left, you have internal control where everything, all these nuclei are positive. In our tumor here, everything is negative. A little higher power on the right. You see some internal control cells that are positive, and then our tumor itself, negative. Let's talk about that. SparkB1 is a member of the SWE/SNF complex. That's involved with chromatin remodeling. These mutations are not uncommon to cancer. They can be seen in up to 20% of all cancers, and these are engaged in tumor suppression. The protein loss, the deficiency that we speak of, is secondary to loss of function mutations. Our control cells, our non-neoplastic cells, will retain that protein. So that's why we see that negative staining pattern if you're new to these. Typically seen in adults, just over 50 years of age. There are several subtypes, but predominantly basaloid or eosinophilic and 2/3 and 1/3 respectively. Poor prognosis, chemosensitive. Let me take you to our last emerging entity in the sinonasal tract. This is the HPV-related multiphenotypic sinonasal carcinoma. From this power, again, we see that cribriform pattern. We can think about adenoid cystic carcinoma or basal adenocarcinoma or epithelial myopithelial carcinoma, intraductal carcinoma, a few of those we've talked about today. But this one's going to stick out a little bit. It'll have a distinct relationship with the surface epithelium and have a distinct immunophenotype as well. Taking a look at the right, this tumor can be destructive. It can be large and destructive. It can move in sheets. Another one of those tumors that can show you a uniform cytology. But if you give your retina a chance, you actually see that some of these nests or tubules have a distinct second population on the periphery, giving it that biphasic look. Looking on the right, the tumor involves that surface epithelium that I told you about. We shouldn't see that adenoid cystic carcinoma. Maybe adenoid cystic carcinoma can colonize surface epithelium or mucosa, but it shouldn't be coexistent with dysplasia. Sure, it happens, but uncommon. This tumor is a signature finding is that dysplastic surface epithelium, so uncommon. That cribriform architecture is in the middle and just thick ribbons, monotonous cytology on the left. Easy to pull out, tease out that biphasic pattern. On the left, you see a P63 immunostain, and it's staining that peripheral cell population and sparing that internal, that luminal population. You can see that in adenoid cystic carcinoma, but you shouldn't see that in, say, maybe a squamous cell carcinoma. You'd expect to see a more diffuse staining pattern. P16 positivity, strong and diffuse. And of course, no matter how you test for HPV, whether it's DNA or RNA, ish or otherwise, these are positive. These are positive. A couple take-home points on the HPV-related multiphenotypic sinonasal carcinoma. This is for adults over 50 years of age, usually around 54, often presenting in advanced stage, relatively indolent behavior, which is an interesting finding. let's wrap it up. Let's wrap up our sino-nasal emerging entity findings. Again, gross and histological overlap common. Several disease-defining genetic markers have been identified in just the last 7-8 years alone. So just as we're seeing in salivary gland pathology, we saw this coming. It's here. It's impacting our classification. It also impacts our laboratory testing algorithms. Most of these tumors are aggressive, and the prognosis of treatment may vary between tumors. Often varies between tumors, I should say. With that, I'm happy to take questions from the audience. I guess I can read those in the chat or.
Dr. Garcia, thank you for that excellent talk and on finishing on time too. So I think we can take few questions. Actually, there were a lot of questions. So few of them I'll read out so that you can answer live, and maybe the rest you can answer in the chat box. So one question was regarding the IPMN, which I suppose you have not mentioned on intraductal papillary mucinous neoplasm. So that was a query that had come up, and its relation to mucinous adenocarcinoma.
Dr. Anila, are you reading a specific question? I just want to make sure I'm following here.
Yes, sir. Yes, Dr. Garcia.
Are you reading a particular question?
Yeah. I think we'll go like this. There are a few questions in the chat box. Few of them we'll answer live, and the rest you can answer according to your convenience later in the chat box. Is that okay with you?
That sounds good. Okay, so you're starting with the first question. I'm just trying to find.
Yeah, it was regarding intraductal papillary mucinous neoplasm and its relation to the mucinous. Yeah, mucinous adenocarcinoma.
Yeah, so I think there's IPMN in relationship to mucinous adenocarcinoma. I think there's maybe an unsettled court on this. I've talked to Justin about this. I guess the question is does this represent some sort of precursor lesion or have a relationship to an invasive tumor? Not a uniform decision on that. I think people have a similar discomfort when they think of intraductal carcinoma and salivary duct carcinoma. There's evidence to suggest that in cases there's a relationship, and in the other cases there isn't. So I know it's not a satisfying answer, but I think it represents the diaspora of opinion right now.
Yeah, I think that will be sorted out maybe in the next WHO edition only with more data. Yeah. And regarding another question is, I think that was a difficult case from one of our consultants. She has written in epithelial myoepithelial carcinoma, can the epithelial component alone produce a distant metastasis, extensive metastasis to the lung, liver, bone and all? That was one part of the question. And second part is, can the metastatic sites show diffuse c-KIT positivity with a lesser amount in the primary? So is that possible?
Yes. Okay. So let me first answer the question about EMCA, and I think the question is, can the ductal or luminal component metastasize on its own? So when we think of epithelial myoepithelial carcinoma and its biphasic nature, we do occasionally see areas where there's one cell type, but it's usually myoepithelial. We call that myoepithelial overgrowth. To that end, when we see metastases of epithelial myoepithelial carcinoma and there's one predominant cell type, it's usually myoepithelial. I can't recall a case that I've seen where the metastasis was all luminal or ductal. I'm not saying that's not true. That sounds like a phenomenal case, and I wouldn't be surprised if it's out there. CD1, how common is it to get CD117 positivity in metastatic site while only scantily positive in the primary site?
Yes.
Really good question. It makes me regret not staining more metastases with CD117. I typically don't use CD117 on the primary because, and the reason why is EMCA is a biphasic malignant tumor, and CD117 can also stain adenoid cystic and basal adenocarcinoma. But I really like this question. I think biologically you might be onto something. So I wish I had insights into that. I just don't. Yeah,
it is something that you can't rule out, no? That possibility is there. It can happen. Yeah, that's what, yeah. So the next question is about the difference between microsecretory versus secretory carcinoma. So morphologically, will you have a difficulty with you calling microsecretory as a secretory carcinoma?
Yeah, really
I
good
think,
question. Go ahead. So I think microsecretory, at least to me, tends to be, more delicate tumor architecturally. It almost looks like it has like a delicate scaffolding to it, has a thin attenuated cytology with it. The secretory carcinoma seems to be a little more sturdy. Even though it's cystic, you'll often find solid areas. You'll see like maybe even a fibrous background. That their cytology will have a vacuolated cytoplasm. So they don't seem to me as attenuated or flattened when they're around those ducts or glands. They actually seem to bulge out oftentimes, both the nucleus and some of that cytoplasm. Cytoplasm seems to be more distinct in secretory carcinoma as well. Of course, if you find yourself in a jam, you can apply cytogenetics, but that S100 strong positivity and maybe mammoglobin and GCDF P15 will probably get you there as well. Secretory carcinoma is most commonly seen in the major salivary glands, which is not true for microsecretory carcinoma, adenocarcinoma, which is mostly seen in minor salivary glands, specifically the oral cavity. I hope that helps.
Yeah, that helps because in our scenario, we don't do too much molecular. We are not having that facility for each and individual cases. So this was
very expensive.
Yeah, this was really helpful. And one more question is how to differentiate minimal intraductal epithelial proliferation and prominent stromal desmoplasia. How can we differentiate intraductal carcinoma from other invasive carcinomas with epithelial myoepithelial components? So how to differentiate? Yeah.
Okay. It's like in cases with minimal intraductal epithelial proliferation and prominent.
Yes, that one.
How can we differentiate intraductal carcinoma from other invasive carcinoma, epithelial carcinoma components? Okay. Wow, tough question. You obviously have a deep understanding of what's going on here. So I guess distinguishing intraductal carcinoma from epithelial myoepithelial carcinoma. I don't really find myself in that position too much. I guess why? I think the cytologic components of the EMCA are fundamentally different than what we see in the intraductal carcinoma. In the intraductal carcinoma, I'm not sure if we're actually seeing myoepithelial cells as much as we're seeing basal cells. And I say that because I don't think in intraductal carcinoma, when you look at those morphologically, it's often difficult to say that's two cell types because that peripheral cell type is not very prominent. I don't think that those cells have a lot of contractile elements in the cytoplasm, so they're not prominent. And so that's why I don't think they're myoepithelial. I think they're more basal. Whereas when you look at an epithelial myoepithelial carcinoma, that peripheral, that external cell type is distinct. It's often is just as tall, just as wide as that ductal or internal component. Its cytoplasm can be just as voluminous. 80% of the time, it can be clear. In in a classic case, of course, you get that jam-packed gland, and then some interspersed myoepithelial overgrowth. A little bit of a different look for intraductal carcinoma, but I think you really just kind of have to work through the case because I'm not gonna say that you're gonna end up always making the distinction. They can be tough. Great question.
Yeah, and one more thing, if we have to do NGS after recurrence, which tumor sample is best in head and neck? Do you have to select the primary sample or the recurrence, that sample?
Yeah, boy, it's really interesting, isn't it? As a pathologist, there's this temptation to say the primary tumor, that's the best tumor, and we would probably say we would say that it was formalin fixed and wasn't frozen. We have a good block for it. But some of our clinical colleagues will actually say that we're not treating the primary tumor. We're treating the metastasis. So we want to know the genetic profile of the tumor cells that we're actually able to escape that primary bed. With that being said, probably requires a conversation with those treating the patient. At the minimum, if you can't talk to the treating clinician, then maybe you just go for the best tumor at the minimum. And if you had to make a choice, I would do MET.
Okay, thank you. And final one comment, my personal query, like the HPV multiphenotypic, that if you're getting P16 positivity in a tumor which resembles adenoid cystic carcinoma, so that per se doesn't make it into that HPV multiphenotypic type. So am I to understand that we have to substantiate it with the mRNA-ish, and then only we can say, because the treatment, there is a lot of difference in the outcome between these two tumors?
Great question, Dr. Anila. I think that's safe to say. At least in our practice, when we have what looks like morphologically HPV related and it's P16 positive, unless we're out of tissue, unless we're out of money, we actually will perform the HPV. We think understanding these tumors, these patients, they can be, they can be alive and healthy 5-10 years out.
Yeah.
It's important we try and classify them as best we can. And I think, in the clinical world, categorically speaking, having an HPV-driven disease, that category means something to them, just as a neuroendocrine tumor does. So I would say,
because P16, I suppose, can be positive in adenoid cystic and a whole lot of other tumors also.
Absolutely.
Yes. Yeah. So I think we are good and we have finished off in time. Thank you so much once again, Dr. Garcia. It was a pleasure having you in our webinar.
My pleasure. My only complaint is I wasn't there in person. Next time I'm coming to Kerala.
So thank you, Garcia. You stick on to time, and most of the queries you answered, right?
Something I got wrong. Huh? So, thank you. It's been an honor and a privilege. I look forward to seeing you all in person. If you happen to be at CAP in New Orleans, make sure you love to talk.
Yeah. Thank you and have a good day.
Yeah. Thank you very much.
Thank you, Dr. Joaquín, Garcia, and Anila Madam for that wonderful session. So we'll move on to the next talk. To introduce the next speaker, I invite Dr. Lata Abraham, Senior Consultant and HOD Pathology, Rajagiri Hospital, Alva. She was a former professor of pathology at MOSC Medical College, Kolanjeri. Her area of interest include oncopathology and hematopathology, and she has over more than 40 publications in her name. Over to you, ma'am.
Thank you, Dr. Annie. And thank you, Rajan sir, for giving me this opportunity to be part of this academic event. And it is my pleasure to introduce the next speaker of the day, Dr. Munita Bal. Dr. Munita Bal is Professor of Pathology at Tata Medical Center, Mumbai. She did her MD from the prestigious Postgraduate Institute of Medical Education and Research, Chandigarh. Her areas of specialization include head and neck and gastrointestinal pathology. She is a member of the National Cancer Grid Guidelines for the management of head and neck and gastrointestinal cancers. She is also an invited member of International Collaboration on Cancer Reporting and invited member of the International Head and Neck Scientific Group. Dr. Bal is author contributor to the 5th edition WHO classification of head and neck tumors. She is associate editor of Journal of Clinical Pathology and has more than 100 publications to her credit. She has also authored several book chapters. Head and neck squamous cell carcinoma is one of the most common type of malignancies we come across in our routine practice. Pathologists have critically important role in diagnosis as well as in recognizing key predictive and prognostic factors in these cases. And we are fortunate to have with us today Dr. Munita Bal with her long years of experience in head and neck pathology to share her experience with us. She will be discussing the tracks and the tricks in the diagnosis of squamous cell carcinoma to us. Over to you, Dr. Munita Bal.
Thank you so much, Dr. Lata, and good evening and good morning to all for listening to us. I'm very glad to be here with everyone, and I bring greetings from Mumbai, Tata Memorial Center. My topic for today is, how do I move? Can you see my slide?
Yeah,
Yes,
we
ma'am.
can see that.
Okay. So the topic is squamous cell carcinoma, traps and tricks of the trade. If we look at the journey of the head and neck cancer patient, it is a long road. And it starts with the diagnosis. If the diagnosis is correct, the patients will reach the correct destination. Now, you would say that most of the head and neck tumors are squamous cell carcinoma. What is the big deal? And that's exactly what my trainees also feel. They see if they're posted in head and neck, it's going to be a squamous cell carcinoma. My surgeons also joke around and they say you don't even have to look at the slide. You just don't have to look through the microscope. You can just write squamous cell carcinoma because it's going to be squamous cell carcinoma. But can I drop my guard? You can see squamous cell carcinoma can have can have many faces. These are all squamous cell carcinomas, or maybe not. If I tell you this is the only one which is an actual squamous cell carcinoma, and if I drop my guard, I can call any one of these other tumors also as squamous cell carcinomas. So here we go. We are basically, today I'm going to be discussing the near misses, the trapdoors, and the potential pitfalls in a diagnosis of our everyday squamous cell carcinoma. Let's see this case. Can I hide the screen somehow? Oh, just a minute. Yeah. Okay. Now, this is a case, a hard palate biopsy, which is showing a lot of squamous proliferation, keratinization. We can see these keratin pearls, something which is very easy for everybody to recognize. The students start recognizing these pearls right from the day one, and that's how squamous carcinoma diagnosis is so easy for them. Well, this is one of the benign tumors which can show extensive squamous differentiation, and that is pleomorphic adenoma. And pleomorphic adenoma, especially in the oral cavity in the hard palate, is notorious for forming these excessive keratinous cysts which are filled with keratin, and these can totally take away. If you're looking at a biopsy and you can think that this is squamous cell carcinoma, unless you pay attention to some small nitty-gritties and things that form an alert for me that this might be a salivary gland tumor and not just a squamous tumor is if the tumor tends to be submucosal. Especially if the tumor cells are too uniform appearing, and if the tumor is looking very pretty, the cells look pretty uniform and not very pleomorphic and ugly looking. If the stroma is very sclerotic and hyalinized rather than desmoplastic, or if the stroma is very myxoid. So we go back and we see that there are a lot of squamous and keratinization happening there, but the background is quite myxoid. And that's when we start looking for these tubules, which may be hiding in the background. And we start noticing that there are indeed some tubules and some ductules and some tadpole-like cells with some squamous metaplasia. So immunohistochemistry can help when these are very subtle and the tubules are not very apparent, because we can do myepithelial markers, S100 or other whole lot of markers to highlight these the myepithelial cells which are present in salivary glands. So that can help distinguish from squamous cell carcinoma. So another tumor which in a biopsy can look like a squamous cell carcinoma is a high-grade mucoepidermoid carcinoma, or even a regular intermediate grade can, in a biopsy when you have sparse mucus cells, can give you problem. But the one thing that is striking when you're looking at a biopsy and you find that your squamous carcinoma is indeed looking very underwhelming. The atypia is underwhelming. The cells don't look as pleomorphic and as atypical, and the tumor overall looks very pink and very subdued. We should then start looking for these mucus cells and perform our mucin stains to highlight these hidden mucus cells, because this could be a mucoepidermoid carcinoma. So mucoepidermoid carcinomas, high grades are rare, but you may come across mucoepidermoid carcinoma in a biopsy, which can look very squamousy. And if you find the tumor is less pleomorphic, look for mucin-filled goblets. Unfortunately, IHC does not help in distinguishing squamous from mucoepidermoid carcinoma. So in a case, if you really need to make a distinction between the two, then you can go for mammal 2 fusions. You can do a FISH, because mucoepidermoid carcinomas, about 60 to 80% would show mammal 2 fusions. You would argue that why do we need to make that distinction on a biopsy? For most part, we do not need to make a distinction. Even if you can't make a distinction between a squamous carcinoma or a mucoepidermoid carcinoma, you can say it's a carcinoma with squamous differentiation and give differentials, because most of the times treatment would be surgery. But in certain situations, like for instance, if the tumor is in the base of tongue, where for a squamous carcinoma, the surgeon may want to send the patient for chemoradiation as a primary therapy, versus a salivary gland where surgery becomes the primary modality. You may have to do a molecular, but those instances are very rare. Most of the times we are able to make this distinction with careful morphology. Another salivary gland tumor that can be mistaken for squamous cell carcinoma is a hyalonizing clear cell carcinoma. This is a tumor that if you don't pay attention can look very squamousy. And the thing is that you would find that the tumor cells are very bland looking. Again, in comparison to a regular squamous cell carcinoma, even a well-differentiated squamous cell carcinoma, in comparison to that, a hyalonizing clear cell carcinoma tumor cells, the nuclei are pretty bland. They don't show that degree of cytologic atypia. And then you start looking for mitosis. So mitosis is, this is a tumor that shows very few mitosis relative. So if your squamous carcinoma is looking bland and not showing mitosis, too many mitoses which are you're not able to find them, then start looking for the stroma, because this is a tumor which tends to be in islands, and between the islands it tends to show a desmoplastic stroma, and within those islands the stroma tends to be more sclerotic. So again, dangerously, this tumor is also P40 positive, similar to squamous cell carcinoma, so may not be helpful. But this is a tumor which tends to show EWSR1 rearrangements. So FISH can help us again. So if your squamous carcinoma is too bland and mitosis are hard to find, think of this diagnosis. This is many times the cells are clear, but they may not be very clear and may be more eosinophilic. So in those cases, IHC doesn't help, but it is essential to keep in mind that this is a tumor that can mimic squamous carcinoma. So again, another tumor. We work in a place where every day we see about tons and tons of squamous cell carcinoma. So we call it a factory. So in our factory, if I see a tumor like that, it can easily pass off as a poorly differentiated squamous cell carcinoma. So before calling anything poorly differentiated, when I'm seeing tons and tons of squamous carcinomas, as a dictum, I try to look for differentiation so that I don't miss anything. So if you see, before signing out anything as poorly differentiated, I try to see that I do find indeed some differentiation. So you see a tumor like this, a pink tumor, and you find that there is unequivocal squamous cell is not identified. So it's always best to do immunohistochemistry. And you're saved if you had put P40 or P63, because if the tumor is P40 or P63 negative, it is not squamous carcinoma. And you're relieved that you had put this immunohistochemistry. And then you start seeing whether this poorly differentiated tumor, you start looking for glands, whether this is an adenocarcinoma. And you can also, it's a clue if you find a comedonecrosis, because though basaloid squamous cell carcinomas will also show you that, but you start looking for these things when you find that the tumor that you're seeing is not squamous, and CK7 in this is positive, androgen receptor is positive, so it is a salivary duct carcinoma, which in a biopsy can very much look like a squamous cell carcinoma. So if it's a poorly differentiated tumor and unequivocal squamous differentiation is not identified, it's best to do P63, or P40, which is the biggest saver. And you start looking for glands, and comedonecrosis is a clue. And then it's a child's play. Then if you get AR positivity, GATA3, GCDFP positivity, and bonus if you get HER2 positivity as well. So if before you sign it out and question if it's squamous cell carcinoma, you just wait, it could be salivary as well. So another case, a 51-year-old male, buccal mucosa biopsy. Again, a regular day, I can easily call this squamous cell carcinoma. But here you see that the tumor is again, then as a dictum, I start looking for differentiation. Is it really squamous? Because I'm just going to call this poorly differentiated squamous. So when I find that, wait, let me look at the architecture. If you see it, low part, the architecture is more lobulated, the surface is relatively unremarkable, but the tumor is more lobulated, and probably there are some nested appearance here. And then I start looking carefully, and then I find there is some spindling here. And then this is such a tumor that I would like to do immunohistochemistry, and definitely requires P40. And lo and behold, this tumor is P40 negative. So it's not a squamous carcinoma. And we do say SOX10 and HMB45, those are positive. So who could have thought this was a melanoma? And over years, we have realized melanomas can look very epithelial. It's a dictum that melanomas can look like anything. And in the oral cavity, we have to be on our guard. Melanomas can be tricky, and they can look like a carcinoma. Another case of 52-year-old hard palate, looks like a regular squamous cell carcinoma, but you again find that this was again turned out to be melanoma. There are some large cells, there are some multinucleate cells, very, very pleomorphic tumor, but we just need to be on guard that whenever you are, for every DD of a poorly differentiated tumor, melanoma is there on the list because it's an omnimorphous tumor. It comes in all shapes and sizes, but we're glad that we have an easy marker to distinguish. We have P40 and P63. So when in doubt, it's always best to do it. Never forget melanomas if you're dealing with a poorly differentiated tumor. So another case of an oropharyngeal biopsy, you're very happy you easily found the tumor. Half the time when you get an oropharyngeal biopsy or a tonsillar biopsy, it's hard. You're dreading that you may not find the tumor. Okay, so this is a easy, lovely tumor. And you're all further happy it's P16 positive, nuclear cytoplasmic, and you're about to sign it as HPV-related squamous cell carcinoma. But are you sure? Are you sure this is squamous carcinoma? Because you know that HPV-related are more basaloid, more blue tumors. And then just be careful. It might just be you might need to do some neuroendocrine markers because synaptophysin and chromogranin was positive in this case, and this case showed this retinoblastoma loss. The small cell neuroendocrine carcinomas, though a subset of them can be associated with HPV, but otherwise also they show P60 loss. That is because they have this retinoblastoma. Its P16 axis is altered in these. So if you have a poorly differentiated blue crushed squamous cell looking tumor, it's wise to add neuroendocrine markers as well. So we know lymphomas are there, which whenever we're dealing with a poorly differentiated tumor, we need to exclude lymphomas. Particularly two lymphomas which can look like carcinomas is one of them is ALCL, anaplastic large cell lymphomas. They are the ones which can really look epithelial, and so we need to keep in mind. And whenever it is when your markers are coming negative, keep in mind that ALCL could be there, and you can do CD30 and ALK1 and see if this is an ALCL. Another lymphoma, which can really look like a carcinoma, especially at the mucosal sites, is a plasmablastic lymphoma, which is usually it is associated very, very significantly, has association with retroviral infections. In our series of about 32 cases, about 28 cases were associated with retroviral infection. So that's a very big clue. And these tumors tend to be mucosa-based, so they can be mistaken for carcinomas. And so it's essential to put P40, if it is a P40 negative tumor in a retroviral infection, think of plasmablastic lymphoma, and these tumors can be LCA negative, they are CD20 negative, And it's important to remember CD138, which is a marker for plasmablastic differentiation. Plasmacytic differentiation is also positive in carcinomas. So these are things that we need to, these could be the pitfalls. So amongst the lymphomas, when we again go to tonsillar biopsy, this is a case where we have a tonsillar biopsy with gland. There's a lot of tumor, but again, this is a poorly differentiated malignant tumor. I'm definitely going to add P40 or P63 in this, and I find that this is P40 negative, and so. And this kind of patchy positivity of P40 is non-specific. If it is to be squamous cell carcinoma, it should be diffuse and strongly positive. So we do P40 is negative, and lo and behold, I start working up that case. And to my horror, it is negative for all markers. It is negative for lymphoma markers, neuroendocrine markers, Merkel cell, melanoma, salivary gland adenocarcinoma, SMART1, BRG1 is retained. NUT is negative, vascular markers negative, round cell tumor markers negative. So this is it. So there is one diagnosis that comes to my mind whenever I'm exhausted, and that is when I put CD21 and CD35, which are follicular dendritic cell markers. So follicular dendritic cell sarcoma is one of my diagnoses of exhaustion. When you have exhausted all your differential diagnosis, do remember this diagnosis. And more commonly, we find that in typical follicular dendritic cell sarcoma cases, they are spindle, they show whirling, and there is this sprinkling of lymphocytes that mix with these spindle cells. Those are easy cases, but remember that FDC has a huge spectrum, and it can show very epitheliomatous or a very syncytial appearance where it can be mistaken for carcinomas. And tonsil is one of the preferred sites for extranodal FDC sarcomas. So it is important to remember this. And the biggest clue is that here the cells are in a syncytium, and there is sprinkling of lymphocytes all throughout the tumor. So the FDC markers should be used, CD21, 35, CD23 cluster in the 40 to 40. But remember that these can also be focally positive for cytokeratins, and that's a pitfall. So it's worthwhile to remember. So if it's a poorly differentiated tumor, again, always exclude lymphoma. And if you're exhausted, if you're not finding any diagnosis, do think of this entity, follicular dendritic cell sarcoma. So another case, an alveolar biopsy, you find a tumor here, and you find that there is a lot of proliferation of squamous islands, and looks easy, looks infiltrative. And then you find that the tumor is showing a lot of peripheral palisading. It's showing very conspicuous peripheral palisading, and that's when you start looking for other things like reverse polarization, and you find that the nuclei are away from the basement membrane, which is called as the reverse polarization, and that is a feature of amyloblastoma. So amyloblastoma can show a lot of acanthomatous differentiation. It can show a lot of squamous appearance, where the stellate reticulum is almost completely squamous in appearance. And it can be associated with a lot of pseudoepitheliomatous hyperplasia, where in a biopsy, this small island of stellate reticulum can be totally missed. So whenever you are seeing something with palisading and reverse polarization, it's looking like a squamous carcinoma, then it's always wise to pick up the phone and call the radiologist and ask where the epicenter of the lesion is. And clinically, usually that diagnosis is not a big problem. And we have had cases where in a biopsy, amyloblastoma was called as squamous carcinoma because of this florid acanthomatous squamous appearance. So it is a pitfall in a biopsy, and we should be aware of it. So if it is in the bone, you should check. It could be an amyloblastoma. Sometimes there can be cases like this where you have like here we had a 28-year-old male who had cervical lymph nodes, unknown primary, and here we found that in the biopsy was done. Again, it looked like a straightforward metastatic squamous carcinoma, and it was earlier signed out as metastatic squamous carcinoma. But then a PET scan showed that the patient had a lot of abdominal generalized lymphadenopathy, and then we went back and we saw and we found these large hyperchromatic multinucleated cells, and we did GATA3, and that turned out to be strongly diffusely positive. Now, squamous cell carcinomas, the mucosa base, they usually don't show GATA3 positivity. The cutaneous ones can show, and it is then we asked them if they had done germ cell markers. And this patient was found to have high levels of beta-HCG on serum in thousands. And then this was found to be a metastatic choriocarcinoma. So sometimes you will have metastasis coming to the craniofacial bones. Another case in a jaw, where in a young female of metastatic choriocarcinoma, which can be mistaken for a poorly differentiated squamous carcinoma. This is associated with abundant amount of necrosis and hemorrhage. And then there are these trophoblastic cells, syncytial, again, a tumor which is showing very pleomorphic appearance. But it is important to remember that you can have surprise visitors in the head and neck, where you have the craniofacial skeleton can be a part of a disseminated malignancy, where the bone mets can present first as a primary, and they can present as a primary tumor, and they can resemble the primary squamous cell carcinoma. So another tumor, 27-year-old lady with a hard palate mass, a blue tumor, basaloid appearing. Cells are, they look undifferentiated and round, and but appearance-wise, and here, lo and behold, I've been talking about differentiation, so I find keratinization, so it should be a squamous carcinoma in our books. But now that we know of various new entities, if we do P40, again, we could have said this is fair and square squamous carcinoma. But then we went with, but the contrast of abrupt keratinization with round cells, with the squamous cells without any transition, and with the cells having a very undifferentiated monomorphic appearance, it was required that we did not. And this is a tumor which is nicely showing this speckled kind of nuclear positivity for nut. So this is nut carcinoma, one of the recent entities which Dr. Garcia just very beautifully discussed. And this is a very, very poor aggressive tumor. And sometimes now our clinicians call up and ask if this squamous carcinoma is very aggressive, it's in the midline, can it be a nut carcinoma? So some of the cases we have found, which we have called squamous carcinoma because of abundant keratinization. When nut was done, they were found to be nut carcinomas. So it can have a round cell morphology, it can show abrupt foci of keratinization, but it can have extensive keratinization also, as we learned in some of our cases. And it can really be, so do not stop short at P40 and say call it squamous carcinoma if you find a lot of undifferentiated or round cells in a background of keratinization. So another entity, to a 52-year-old male, sino-nasal mucosa. Again, a basaloid tumor. Is it a basaloid squamous carcinoma? But here we find rhabdoid cells, beautiful cells, and SMARCB1, again discussed by Dr. Garcia. This IC becomes very relevant when we see these kind of rhabdoid cells. In fact, all the tumors in the sino-nasal tract now which show an undifferentiated appearance or even basaloid appearance we should do SMARCB1. And here the tumor is negative and the internal control of the stromal cells is positive. So this is a SMARCB1 deficient tumor showing basaloid cells. It can show rhabdoid morphology. That's a very big clue. And it's an IHC diagnosis. Another entity which has pathology features which are hybrid between Ewing sarcoma and squamous cell carcinoma is an adamantinoma like Ewing sarcoma. This can once in a while come up in your life, and you like Ewing sarcoma, it has this blue round cell morphology. You have cells which are round, monomorphic, like Ewing sarcoma, but they tend to show nested appearance, nested architecture. And like Ewing's, they have this membranous MYC2 positivity, NKX2.2 positivity, and they show EWS-FLI1 fusion. But like squamous cell carcinoma, they can show abrupt squamous differentiation. They can even show keratinization in about a third of cases. And that's when it can, you also have a differential of nut in these cases. right? So because we see squamous differentiation, we may think that this is easy and it is squamous carcinoma, but keep in mind the background. If the cells are blue, round, like Ewing, do the IC4 Ewing marker. And interestingly, this is also a hybrid on immunohistochemistry that it shows diffuse P40 positivity. So these few entities are really really something that we need to now be aware of, that whether it is a squamous carcinoma or one of these new entities, new kids on the block. So again, now we finally come to squamous carcinoma, or is it? So now we see a lot of irregular infiltrative islands, a lot of clear-cut squamous differentiation. But when we look at the LOPAR, we find that this proliferation has these kind of buds and branches and these small nests and whorls. And then we look at the LOPAR, very important to go at the LOPAR, and we find that this is a very ductal lobular architecture. You have a duct, and centered around that duct, you have these lobules of these squamous islands. Now, squamous carcinoma never does this, never is in a lobular architecture. So this kind of a lobular architecture is very, very striking in this, and you start looking at that lobular proliferation, and you find that there are ductal lumens, and then you find that the quality of this squamous proliferation is bland and very eosinophilic and metaplastic. And here you can see some these are in fact plugged ducts which are showing squamous metaplasia, and this is silometaplasia. And in a biopsy, because of this kind of infiltrative pattern, it can look very, very alarming and worrisome, and it can be mistaken for squamous cell carcinoma. And in our setting, post-radiation or post-radiation, we get to see as a reparative change the silometaplasia, and it can be a pitfall. Another thing where the squamous epithelium can look very alarming is next to an ulcer. So in this active ulcer, the epithelium which is just hanging on to the edges of that ulcer can look really alarming and very epitheliomatous. So around an ulcer, an irritated mucosa can look very, very alarming, and it's always best to look beneath that and see where the real pathology is. Because, for instance, in this case, we saw that in one of the cases, in ameloblastoma, we had a florid pseudoepitheliomatous hyperplasia, and that can take away from the real lesion, and it can misguide. Another tumor which is famously associated with pseudoepitheliomatous hyperplasia is granular cell tumor. It can be the problem with granular cell tumor is that it can be totally missed, and the tumor cells in the subepithelium can totally blend with the connective tissue and can be totally missed. And the worst problem is that the pseudoepitheliomatous hyperplasia can be totally mistaken for squamous cell carcinoma. So another case here where this florid pseudoepitheliomatous hyperplasia, this was so florid that it was mistaken for squamous cell carcinoma, and the lymphoma which was there underneath, that was totally missed, and it was in this repeat biopsy that the lymphoma was picked up. So the takeaway about this, about the first part of this is that before we sign out squamous cell carcinoma, see if there is a ductal-lobular architecture, and then because if there's a ductal-lobular architecture, it's not squamous cell carcinoma, it's a silometaplasia. If the epithelium looks very irritated, do not forget to look underneath. It could be pseudoepitheliomatous hyperplasia, and the real lesion may be hiding underneath. And if the cells look too bland, and if there are goblets, and if you find that the lesion is quite submucosal, if the stroma is quite hyalinized and myxoid, and the cells look very pretty and the cells look very uniform, think salivary gland, it may not be squamous. And if the epicenter is in the bone, tumor cells show palisading and reverse polarization and a stellate reticulum, yay, it is ameloblastoma. And before we find out the poorly differentiated squamous cell carcinomas, we should do P40 or P63. If the tumor is P40, P63 negative, Then it could be melanoma, neuroendocrine carcinoma, salivary duct carcinoma, lymphomas, and even metastatic carcinoma. So these are our possibilities that we have to be aware of. And then we cannot miss the new kids on the block. We do not stop at P40 and P63. If we find squamous differentiation, we have to look for these round cells, undifferentiated cells. If they are there, we go ahead and do not. If we find rhabdoid cells and undifferentiated cells, basaloid cells in sino-nasal location especially, we do SMART B1. And if we do find abrupt keratinization and squamous differentiation, but we feel that the background is like a round cell tumor, it could be an adamantinoma like Ewing sarcoma. So these were some of the differential diagnoses. And if we keep in mind, then the diagnosis we can achieve the diagnosis. So our job is, when I was a trainee, I thought that my main job was to make a diagnosis. And I thought that making a diagnosis was all that a pathologist is supposed to do. And then when I became, then subsequently, especially after working in an oncology center, I realized that the job of a pathologist changes with the clinical setting and with the specimen that they get. And each specimen that comes with a clinical question, and it changes with the clinical setting. So in a preoperative setting or in a setting when the workup is being done, our job is to give the diagnosis. But once the diagnosis of malignancy is made and clinical staging is done and a patient is operated, in the next stage, we get the resection specimen. And in a resection specimen for an oncology case, our job changes, our role changes, because the diagnosis is usually known in most of the cases. And our job becomes different. It becomes, we need to address these key questions. And the questions are that whether the surgery is complete, what is the stage, pathologic stage of the tumor, and what is the biology of the tumor. And so that becomes the essentials of pathology reporting at this stage. So we report on the margins to answer whether the surgery was complete. We give the pathologic TNM staging, and we look for pathologic prognostic factors to best tell the surgeon what kind of a disease is it. Is surgery enough, or is it an aggressive disease which will require something adjuvant or additional to surgery? So we look at the resection margins and the margins vary with the type of the specimen we see. So it's very important to be familiar with what surgical resection has been done and to identify the components of the specimen. So if you have to be familiar with the anatomy and the subsites in oral cavity as well as in the head and neck region. And whatever specimen you get, it may be a simple excision where there is just a wide excision, you have a buccal mucosa or a tongue wide excision. Or it may be a complex composite resection where more than one anatomic subsite is removed. So then you have to identify whether it is including a buccal mucosa along with the mandible, or is it including a tongue with the mandible, or is it a bite composite resection where both the mandible and part of the upper alveolar bone is also included. So identifying the components of the specimen becomes essential, and that will help us in choosing what margins we have to take. Also, it's important to be in touch with your surgeons so that they are able to orientate the specimen for you. The specimens that we get in our hospital, all of them are oriented by the surgeon. It's important that you know what is the anterior and the superior or posterior, so that you can label those margins and give a specific report. So margins for an oral cancer resection would be mucosal margins. If the lip is included, it becomes a mucocutaneous margin. Then the deep or the soft tissue margins and the bone margins, if bone is included. So the margins, this whole surface where this is the tumor and this is the rim of mucosa, normal mucosa, which the surgeon has excised, where the surgeon has excised the mucosa, that entire thing becomes a margin. Since we cannot sample everything, so we sample the margin where the tumor is going close, at various places where the tumor is close to the margin. And then the deep soft tissue or that's also referred to as the base, where the surgeon has cut the soft tissue that is inked, and we ink the soft tissue margin, and we take these margins. So margins can be radial when they are taken perpendicular to the cut surface. So the advantage of this is you can also record the distance of the tumor from under microscopy, and the shave margins when the margin is cut parallel to the cut margin. So in the oral cavity, the mucosa is taken radial, the base and soft tissue is taken as radial margins, mucocutaneous margins are shave margins, and bone margins are also shave margins. So if this is a buccal mucosa specimen with a tumor, so we record the distance of the various margins from the tumor, and we sample perpendicularly radial margins wherever the tumor is closest and label them as mucosal margins. Same goes for left hemiglossectomy and other specimens. You have these, identify the margins which are the closest, and you sample them radially. For these wide excisions and others, you would serially slice through the tumor and lay down all the slices on the dissection on the grossing table from top to bottom, and then you examine them and select the ones where the tumor is closest to the base, and you record the distance of the tumor to the base, and you take the samples of the mucosal margins as well as the base. And for specimens which include the bone, you have to identify, for instance, this is a hemimandibulectomy. The anterior cut margin where the mandible has been cut by the surgeon, that forms the cut margin, whereas the inferior ramus and the posterior free, these are free margins, these are not the surgical margins, right? So we take an anterior cut margin, which is a bony cut margin, which is a non-shave margin. So in a right hemimandibulectomy specimen, you'll have a mucosal margins, the lateral mucosal, anterior, medial, and posterior mucosal, and then you have the anterior bony cut margin. So for a bite resection, usually done for retromolar trigone tumors, you would have these mucosal margins where you have the inferior mucosal, posterior mucosal, and the superior mucosal margins. And then you also have the bone margins. For the mandible, you have the anterior mandibular cut margin, and for the marginal maxillary resection, we have anterior maxillary, superior maxillary, and the posterior maxillary bony cut margins. So depending upon the specimen, you take the mucosal margins, soft tissue margins, and the bone margins. Then we go on to the TNM staging. In 2018, we were handed over the HSCC 8th edition. And initially, the T staging that we did was mainly the tumor size, the dimensions of the tumor, and involvement of the adjacent structures where the bone, skin, maxillary sinus was involved. But what changed with the 8th edition was the depth of invasion. It is basically, initially, we just had to give three-dimensional gross findings. Now we have to also see how much is the depth of the tumor. So depth of the invasion is DOI, that is a parameter, it's a histologic parameter, it's a microscopic parameter which the pathologist has to give, and it basically is the maximum depth of the tumor invasion below the luminal aspect of the surface. So if you have, and it is not to be mistaken with tumor thickness. Tumor thickness is basically the total vertical span of the tumor, and whereas the depth of invasion is the deepest point below the surface or below the mucosal surface, where we take the adjacent normal basement membrane as the reference point. So depth of invasion, or DOI, is a microscopy-based parameter. It is not to be mistaken with tumor thickness. They are similar, but they may be different. Depth of invasion is recorded from the basement membrane of the adjacent epithelium. So these are some of the examples where you draw a horizon from the adjacent basement membrane and drop a perpendicular plumb line to the deepest point where the tumor is seen. Again, the tumors may be ulcerative, where the depth of invasion may appear to be falsely low or less. So you have to drop a horizon from the adjacent intact mucosal basement membrane and extrapolate it, and then draw a perpendicular and drop it to the deepest point. That is how depth of invasion is measured. There are issues with it. We'll come to that. And this can be done by a transparent ruler, which is overlaid on the slide, or an optical micrometer. What has become apparent is that extra care is required during grossing. We have to see to it that there are no tangential cuts, that the sampling of the tumor is as perpendicular to the surface as possible, and serial sectioning is at 2 to 3 millimeters. And the grosser is very well aware of which splices are to be submitted for grossing, for sampling, and in fact they should label it that these are with the maximum depth of invasion. So in 8th edition TNM, you can see that DOI is very comfortably sitting in all the T stages, and we can see that basically there is an increase. Earlier only size mattered, now depth is also important. So basically every 5 millimeter increase in the depth, there is an upgrade to the next T level. So what was earlier T1, now if the depth of invasion is more than 5 millimeter, that original T1 tumor is now classified as T2. And if it is more than 10 millimeters, then it is classified as T3. And T4 is if the both more than 4 centimeter size tumor dimension as well as depth of invasion more than 10 millimeters. So the T4 earlier of in the case of tongue, which was based on extrinsic muscle invasion in the tongue, that has been removed. And now we come to the nodal staging. That is also an extremely important job. In the 7th edition, it was fairly simple. We had to measure the size of the node and the size and the laterality of the positive node. But with the 8th edition, one of the most important parameters which has been added, and again, that's a microscopic parameter, and that is the extranodal extension. So any spread through the full thickness of the lymph node capsule, that is defined as extranodal extension. And that has been found to be an independent poor prognostic factor for not only locoregional recurrence, but also for distant metastasis. And that becomes an indication for chemoradiotherapy if ENE is present. So because it has been incorporated into nodal staging, the M staging, so it becomes mandatory for us to report it. So this is one of the cases where you don't see an ENE. ENE is negative. You can see nice lymphoid tissue and capsule, and the tumor is confined within the lymph node capsule. Again, another case where you have lymph node ENE confined within the lymph node capsule, and this is how ENE would look like, where it reaches the capsule and goes out into the perinodal fat. The extent of microscopic ENE is another thing which is an emerging prognostic factor. Jim Lois in 2000, way back in 2011, published grades of ENE, and it's a very good paper because it illustrates how ENE progresses. There are different scenarios in which ENE is experienced. We see under the microscope. 0 ENE when you don't find any extranodal extension. Grade 1 when you find that there is some thickening of the overlying capsule and there is no intervening lymphoid tissue between the thickened capsule and the tumor deposit. Grade 2 when it has extended beyond the capsule and it is less than 1 millimeter. Grade 3 when it has gone beyond 1 millimeter, and grade 4 when you can't identify the underlying lymph node and it comes as a soft tissue metastasis. So that was done long back, and I think it's a very good grading system because this is how we see ENE. We did our own study as well, and we found that the ENE grades were with a cutoff of 1 millimeter. They correlated with poor 3-year overall survival. And ENE grade 3 and 4 lymph node density, and ENE in more than 2 lymph nodes was independently associated with poor prognosis. So it is not mandatory as of now, but it is recommended that the extent of ENE or the measurement of ENE into major or minor should be recorded in pathology reports. The major is defined as more than 2 millimeters, and microscopic is defined as up to 2 millimeters. So measurement of ENE has to be the greatest extent of tumor spread perpendicular to the external aspect of the nodal capsule. So you have to identify the nodal capsule wherever the nodal capsule is identifiable, and then from there on extend it and see what is it has to be measured perpendicularly to the external aspect. So again, you can see in the TNM end staging, ENE, it's based on the ENE is very much a part of nodal staging now. So if N1, previous N1, if ENE is present, then it upgrades to N2A. And the others, N2A to C to N3A, if ENE is present, now it upgrades to N3B. So the other important thing that we have to tell in the prognostic features is the pathologic prognostic features in a resection specimen. So we look for grading, we look for poor differentiation, if there is presence of LVI or lymphovascular emboli, and presence of PNI, they are associated with increased, they are considered adverse histologic features. And in the PNI, we also now try to quantify and qualify what type of PNI it is, whether it is intratumoral or extratumoral, whether it is focal or extensive. We also record the foci density, which is defined as the foci of PNI per tumor section, and the diameter of the largest nerve involved. So we are recording this, and these are supposed to be the emerging factors. And what has been seen is presence of extratumoral PNI is associated, it's far worse than intratumoral PNI. And if it is extensive PNI, having many foci of PNI per tumor section, that is associated with a worse prognosis. So it has been seen that tumors which have pushing type of a pattern of invasion versus very infiltrative type of pattern, they behave differently. And now patterns of invasion are core data elements. We have to report on them. So it basically, there are 5 patterns of invasion, and the worst pattern of invasion is a core pathology data item that we need to report. So basically, the patterns of invasion, there are 5 patterns. They are broad pushing fronts. When you see at the tumor interface, that is pattern 1. If you have finger-like, when they start becoming finger-like and still connected to the surface, they are pattern of invasion 2. And when they start getting disconnected, but still the tumor islands are more than 15 cell thick, that is called as pattern of invasion 3. When the cell cords become too infiltrative and they become thin and they are less than 15 cell thick, it's called pattern of invasion 4. And when you have a tumor deposit which is separated from the main tumor by at least a distance of 1 millimeter, that is referred to as a pattern of invasion 5. So worst pattern of invasion 4 and 5 are supposedly associated with poorer prognosis. And so some of the other emerging factors with squamous cell carcinoma are tumor budding, which is defined as a single cancer cell cluster, which is of less than 5 cells, which are to be seen at the invasive front, and they should be differentiated from poorly differentiated clusters, which are 5 cells or more. And based on the International Tumor Budding Consensus Conference, there is a risk stratification. So low risk is less than 5, high risk is more than 5 budding, and they've been shown to be associated with poor prognosis, especially can be a good risk factor to determine in an early cancer. And it signify a mechanism of EMT, or epithelial mesenchymal transition. So another parameter which is emerging is a tumor stroma ratio, which is defined as the proportion of tumor tissue relative to the surrounding stromal tissue. And it has been shown that if tumors where the stroma is more than 50%, is associated with both cancer-related mortality and disease-free survival. So there are some scoring systems, risk assessment scores, which are available. Histologic risk assessment score is one of the most studied one, which takes a combination of worst pattern of invasion, lymphocytic host response, and perineural invasion, and gives a score to risk to identify which are the tumors which can undergo recurrence. So in our pathology report, it is based on the pathology report and all the features that we report, whether the patient after surgery is observed or is sent for adjuvant therapy. So if the patient has margins are clear, they're R0. If there is an early stage 1, stage 2, and the nodes are negative, then the patient is observed. Whereas if we give a stage 3 or stage 4 node positive disease, and if you have 2 adverse features, that patient goes for radiotherapy. And if margins are positive and there is presence of extraneural extension in our center, they go for chemoradiotherapy. So it's important that in the job that we do, the role that we play in the journey of a head and neck cancer patient changes from diagnosis. And after surgery, it's based on the pathology report, whether the patient, what type of further management is done. So finally, the takeaway is that the role of the pathologist is to identify the clinical question that comes with the specimen, with each specimen, and to answer it. And that varies with the clinical setting. And in a biopsy, your role is mainly to give a diagnosis. In a resection specimen, our job is mainly to provide margins, TNM, and prognostic factors, as much information as we can give. And post-resection, the questions may vary, whether it's a recurrence or not. And so what can sail us through is a little bit of coffee, alertness, and a good, careful histopathology. So this is our joint clinic. We pathologists are a part of our regular multidisciplinary joint clinic, and along with radiation surgeon, radiologists, and nuclear medicine people. And it is here that I learn the most and enjoy the most. And this is our disease management group, head and neck disease management group. This is my like a family. So thank you very much. I'll be happy to take any questions if there are any.
So thank you, Dr. Munita, for a very informative talk. So now we understand diagnosis squamous cell carcinoma is not that easy and straightforward always. It can have many mimics with different prognosis and different management protocols. Also, differentiation of squamous cell carcinoma from pseudoepitheliomatous hyperplasia can be challenging at times. And you have also demonstrated beautifully how the resection specimens are sampled with the use of beautiful diagrammatic representations and also gross pictures. Thank you so much for the excellent talk. Now we will go to some of the questions which are available in the chat box. We may not have time to discuss all the questions live, but a few questions can be discussed. One question is, can we see a zonal expression of cytokeratin and NKX2.2 in epithelial and round cell component respectively in adamantinoma like Ewing sarcoma?
Can you just repeat the question? You want to know whether there is a zonal expression?
Yeah, zonal expression of cytokeratin and NKX2.2 in epithelial and round cell component respectively.
No, so what we see is the diffuse positivity with everything, with MYC2, with NKX 2.2, with P40, with cytokeratin. The tumor is whole and soul, usually whole and soul positive. So
it is irrespective of the morphology.
Morphology, yes.
Yes. Now another question is regarding amyloblastoma when it is peripheral, that is without bony involvement, and acanthomatous type. How can it be distinguished from squamous cell carcinoma?
I think you need to be lucky. First of all, you have to pay attention. I think on morphology, it's not amyloblastomas won't be that pleomorphic. They look cytologically they're bland compared to squamous cell carcinoma, and it's the palisading which saves you, and it is still in some areas
reverse polarity.
You're lucky if, yes, reverse polarity. So when I see palisading and the tumor doesn't look that basaloid and that pleomorphic, then I immediately start seeing that it shouldn't be showing any reverse polarization. And some places you will find some stellate reticulum, but we have seen cases which have been on biopsy called as squamous cell carcinoma because they can look very acanthomatous.
Yeah,
but I think when the squamous cell carcinoma looks a little funny, it doesn't look fit the bill. It looks. I think it's important to just be aware and alert that. If it is not that pleomorphic, not mitotically active and palisaded, then we should be alert. I think good coffee.
Next question is regarding verrucous carcinoma. How is verrucous carcinoma staged? That is, how is the depth of invasion assessed in verrucous carcinoma?
First of all, making a diagnosis of verrucous carcinoma can be very challenging. And the fact that how it is distinguished from verrucous hyperplasia is that it should be a little, it should grow under, it should show an endophytic growth pattern where it extends beyond the basement membrane of the adjacent squamous mucosa. So it has a little depth. That is how we make that diagnosis. And the criteria is the same for making a diagnosis for measuring the depth of invasion. Is you take the adjacent basement membrane, draw a horizon, and go to the deepest point. So the criteria are the same. It is staged the same way as conventional squamous cell carcinoma. The big problem is making that diagnosis, especially on a biopsy. So in a resection, it is still possible.
So we measure the tumor depth below the surface epithelium.
From the adjacent, we draw a horizon, taking the adjacent basement membrane of an intact adjacent epithelium, and draw a horizon, and then drop a plumb line to the deepest point.
Similar to other invasive.
Similar. The rules are the same.
So due to lack of time, I think we can wind up the session now.
You can, 2 more questions can be discussed, right?
Okay. So next question is there any specific guidelines for reporting post-NACT resection specimen in oral cavity carcinoma?
So we at our center, we have some experience of post-neoadjuvant chemotherapy resection specimens, but there are still no guidelines as of how to report and how to measure. So we have devised a tumor regression grading system, but it is, and we are in the process of validating it. And the results will be soon out and published. But as of now, we don't have a grading system or a grading method to measure tumor regression in a post-neoadjuvant setting.
And one last question. Is it advisable to mention tumor budding in small biopsy report?
In a biopsy report, we don't do it. In a resection, in an early cancer, we are recording that. So in a biopsy, it may be very difficult. We are doing it in resection specimens.
You are reporting it routinely in resection specimen?
For early cancers, yes. It's being done. It's not a mandatory element. It's not a mandatory core data element, but it is optional. So we are recording in the early cancers as
related to tumor bud. There is another question: how to differentiate worse pattern of invasion 5 from tumor bud?
From tumor buds.
From tumor buds.
So tumor buds are very, very small clusters. They're less than they're up to 4 cells. Whereas pattern 5 is a bigger cluster, is a bigger deposit. It's like a proper deposit away from the main tumor. It's like a satellite tumor deposit. Usually it is a perineural or a vascular deposit, but you may not see a perineural invasion or vascular invasion, but it's a bigger focus. Tumor bud is a very small focus, single cell cluster or up to 4 cells. So less than 5 cells. The tumor deposits, pattern 5 is a bigger tumor nodule.
So with that, we can wind up the session. Thank you once again, Dr. Munita, for discussing so many practical points in reporting of squamous cell carcinoma.
Thank you so much.
A very useful session for all practicing pathologists.
Dr. Munita, it was very useful session, and SOST session also. You cover almost everything, including the grossing and tumor staging, everything. Okay, thank you. Thank you very much.
Thank you. My pleasure. Thank you so much.
Sir, Dr. Smita here, can I have a question?
Yes,
can I address a question?
Yes,
thank you. Thank you, Dr. Munita. It was such a wonderful talk. You have shared all the curated knowledge of your experience in this wonderful talk. And I just have one query about a condition called eosinophilic ulcer of the tongue, which sometimes comes as a troublesome biopsy, especially in case of recurrent cases with so any experience in that, especially in a known case?
No, I don't have much experience with eosinophilic ulcer. We are out and out malignant.
Okay, because it comes with a diagnosis of a malignancy, especially in case of recurrence. Sometimes it is a trouble for us actually. So if anything.
No, I don't have much experience with this. Thank
Okay.
you.
Okay. Thank you.
Any?
Yes, sir. Thank you, Lata ma'am, for chairing this session, and thank you, Munita ma'am, for that wonderful section, especially the grossing part, which is actually very beneficial for PGs as well as the practicing pathologist. So we'll move on to the last session of the day. To welcome the speaker, I invite Dr. Shalini. Ma'am, she is the senior consultant at Astra MIMS, Calicut. Ma'am, over to you, ma'am.
Okay. Thank you, Rajan sir and Ani, for making me also a part of this webinar. It's my pleasure to welcome Dr. Paromita Roy to deliver the concluding talk of this webinar series. Dr. Paromita has done her PG in IPGMER, Kolkata. Subsequently, she went on to do a fellowship in head and neck pathology in Toronto General Hospital. Following that, in 2010, she joined TMC Kolkata, and currently she holds the faculty position of a senior consultant pathologist there. Dr. Paromita has more than 50 papers to her credit, both in national as well as international journals. She also has an active part in many ongoing research projects. So the topic for today's talk is tackling the stumbling block of salivary gland tumors in a resource-constrained setting. Now, majority of us are working in resource. So majority of us are working with limited resources as regards the wide panel of IHC, or for molecular testing, and most of all, the financial aspects of the patient. So we look forward to gaining some insights from your talk, Dr. Paromita, as how to approach these blocks in our current daily practice and in clinical scenario. Over to you, Dr. Paromita.
Thank you so much, Dr. Shalini. And while I share my screen, I want to thank the Kerala IAPM Chapter for this invitation. Is my screen?
Yes, ma'am. Just need to make it full screen.
Yeah.
Yes.
Am I visible?
Yes,
yeah.
Yes, ma'am.
So thank you, and I've been really enjoying the lectures over the last 2 days. So Dr. Garcia today was excellent, and he's made my job a lot easier by talking about the new entities, which, as you all know, the 5th WHO edition is out, and it has added a few more difficult subtypes of salivary gland tumors, making our life a little more difficult. So in the benign neoplasms, the new entities are intercalated duct adenoma, stratoduct adenoma, sclerosing polycystic adenoma, which was earlier a non-neoplastic entity, and then there is keratocystoma, which was earlier there, but then they brought it back to the classification. And in the malignant entities, there are minor changes everywhere. The two major new entities are microcystic adenocarcinoma and sclerosing microcystic adenocarcinoma, microsecretory adenocarcinoma, and sclerosing microcystic adenocarcinoma. And then there is changes in the salivary carcinoma NOS, which is becoming a non-entity, as Dr. Garcia spoke about. There's the mucinous adenocarcinomas, IPMN, and many more. What the new classification has also done has elaborated and established very clearly well-defined molecular markers of many of the salivary gland tumors. And some of the new entities are actually defined on its molecular identifying marker, which makes life for us in India quite difficult because we don't have access to many of these markers. As Dr. Garcia again mentioned, these tumors are rare. He sees 5 a day, we see maybe 5 a month. So our confidence is a little low. And to add to that worry, there are multiple histologic types. The presentation of each of these types can be very variable and heterogeneous, as we've seen in the examples he has shown. Then Munita had an excellent talk where she has shown you multiple salivary gland tumors which can come in the differential of squamous cell carcinomas. So that makes it challenging. The other very difficult aspect is that benign tumors in salivary gland differentials very often mimic the malignant ones, especially the low-grade malignancy versus benign is something which we encounter most often in our practice. IHC expression, there is newer markers coming out every day, but we don't always have access to the absolutely new next-gen IHCs which replicate the molecular mutations that these tumors are associated with. So the other IHCs can be overlapping between the different entities, which using them can have its caveats, and we need a wider panel to help us diagnose. Then lastly, the tumor typing is important because depending on the type, the tumor grades are defined for these tumors. And if we cannot grade our tumor, the most important job of the pathologist is to do accurate typing and grading where salivary tumors are concerned, because that determines adjuvant treatment after surgery. And lastly, as I mentioned, the molecular tests are not easily available to us. So we have to make do with histology and IHC. So the diagnostic pathway, as we all know, for salivary gland tumors, when a patient presents, the first line is always an FNA. In certain institutes, people do core needle biopsies, but that's not something surgeons or clinicians are very happy to do. So on the FNA, we have to give them a preliminary idea. And Milan system is also now totally recommended in the new WHO, and they have included the cytologic descriptions for each of the entity. So we have to, even if we cannot nail the diagnosis on cytology, which is sometimes difficult, we have to give them an idea as to where this tumor is going. Is it on the benign aspect? Is it of uncertain malignant neoplasm, or is it suspicious for malignancy? And once we are clear that it's malignant, we have to try to grade it as low grade or high grade, because depending on that, the surgeon will decide the next line of management, which is the extent of surgery, whether lymph node dissection needs to be done, that's for the high grade tumors, or not, whether the superficial lobe only needs to be dissected, or the deep lobe as well. All this depends on the grade of the tumor. But the onus is not just on the pathologist. They have their help from radiology as well. So when it's a benign tumor, they would do a USG, and then if they are suspicious of a hard, bigger mass of malignancy, then they would do a CT scan or MRI, and they would take both your cytology report and the radiology before making their plan. So when the clinician sits on your head, don't be pushed to make a diagnosis, make a specific categorization, come what may, because in many of the reviews that we see, that it is wrongly called an FNA, and it ends up in a bigger surgery for the patient. So be careful, try to stretch yourself, but never overstretch for the benefit of the clinician, because they will take into consideration the years that the tumor has presented, which is important history information which helps us diagnose, which they often will not share with you, even when you have access to the EMR. This is the NCCN guidelines for management of salivary gland tumors, and it's important that not just for salivary gland, for any tumor, that the pathologist always goes and checks the NCCN website for what is the management protocol for tumors, because it helps you to have a realistic idea of which components of your report are important for the patient management and which components are more of academic interest. And specifically why I mentioned the salivary gland tumors, because we sometimes feel limited, that we cannot work it up to the full length. We have these limitations. We've done IHCs, we've done all the panel that we had, and we cannot still come to a conclusive diagnosis. even if we can tell that is this benign or is this a low-grade malignancy? If it's a malignancy, and if it's a malignancy, is it low-grade or high-grade? Even that will help clinicians do whatever is needful for managing these patients. So, as I mentioned before, if it is a neoplastic and then the stage is more than T3, high-grade tumor, clinically there are nodes on radiology, then the surgeon will do neck node dissection. And on the resection, if there are adverse features like high-grade, and all adenoid cystic carcinomas are considered as poor biology, which need adjuvant radiation, close or positive margins, the presence of LVI or PNI, accurate staging on the resection specimen, and nodal staging. These are the features, nodal positivity, which determines adjuvant radiotherapy for these tumors. There is a role of chemotherapy as well for recurrent, unresectable, and metastatic salivary gland tumors. And what's important for us to know that nowadays there are targeted treatments available. So if you are diagnosing a salivary duct carcinoma, the patient can be given androgen receptor therapy. HER2 is done, and we follow the breast protocol for HER2 positive scoring, and they can be amenable to trastuzumab and other HER2 targeted therapies. NTRK is now come up, and these patients who have NTRK fusion positive tumors are amenable to the inhibitor therapies. And lastly, PD-L1 is coming up in a big way, and we are often requested to test for them and for immune checkpoint blockage treatment. So now coming to the diagnosis of typing of salivary gland tumors. So before we before I go on to my approach to diagnosing these tumors, we have to come back to histogenesis. So identifying or knowing what types of cells are in the tumor helps us nail down or make the list of differentials smaller. So as we all know, salivary glands can have serous acini and mucinous acini, and the tumor respectively can have variable components of these cells depending on the cell of origin. Then there are these myoepithelial cells, which some tumors can have both the myoepithelial and epithelial component in them, and some tumors can only have proliferation of the myoepithelial or basal cell cells. Then leading from the acini are the ducts. First is the intercalated ducts, which lead to benign and malignant tumors. Then following that is the striated ducts, which are more columnar in appearance. And lastly, the excretory interlobar ducts. All of these areas can give rise to tumors. A good helpful thing, a system that helps me is I paste these charts at my workstation. This is a list of tumors which, based on whether the tumor is a one cell type or two cell type, we can nail down our differentials. So among the two cell type of benign salivary gland tumors, we have, as we all know, pleomorphic adenoma, basal cell adenoma, and intercalated duct lesions. Of the one cell types, there is canalicular adenoma, myoepithelia, and which are more basal looking or spindle looking with myoepithelioma, and the more oncocytic types would be Werdens and oncocytoma, which are of single cell type of tumors. And in our malignant differential, the biphasic ones are adenoid cystic, epimyoepithelial, and basal cell adenocarcinoma. The one cell type can be of ductal origin, like salivary duct or secretory carcinoma, of myoepithelial origin, like myoepithelial carcinoma and polymorphous adenocarcinoma. And then it can arise from actinic cells or tumors with frank squamous phenotype, which are the mucoepidermoid, hyalinizing clear cell carcinoma, or SCC also. So keeping this approach of first trying to find out whether the tumor we have is of one cell or two cell type, my first line of IHC, the pattern that I prefer doing, is using a P63, S100, CK7, and CKIT. sometimes I would actually use only 2 markers to start with. So P63 as a myepithelial marker and CK7 as an epithelial marker. This is a nice paper by Cipriani et al. And they give us a very useful approach to diagnosing, categorizing these tumors. So using the same concept, the morphology of the tumor that we are seeing can be of myepithelial or basal. So the differentials would be myepithelial, clear cell, and squamous carcinoma. They can be of 2 cell types with more myepithelial morphology. So the differential would be epithelial myepithelial carcinoma. It can have a more epithelial morphology and a more basal-like morphology, basal, cribriform, or tubular-like morphology, but of 2 cell types. And the differentials there would be pleomorphic adenoma, adenocytic carcinoma, and basal cell neoplasms, both adenoma and adenocarcinoma. And then tumors with a single cell type of epithelial origin, having a cystic or secretory or mucinous kind of morphology. These, because these tumors tend to have variable overlapping morphology, that they have used a wider spectrum of morphologic differentials to put in their IFC panel. And in this morphologic spectrum, the differentials included are intraductal carcinoma, actinic cell carcinoma, secretory, and carcinoma and canalicular adenoma. And their IFC panel for this group is P63, P40, S100, DOG1, and mammaglobin. Sorry. For the basal cell tumors, they've used, again, a combination of basal markers like P63, P40, and epithelial markers, which are CK7 and CK. And S100, again, as a myepithelial marker. Sorry. Of the solid nested of myepithelial origin tumors, this group needs a wider panel. So again, a combination of, as you can see, myepithelial markers and epithelial markers. So using this approach, I would like to share with you a couple of case examples to show you a real world approach to how I've used IHC panel to nail down the diagnosis. So the first case is an 82-year-old male patient who presented to us with a right cheek swelling for 4 months. The outside FNA, this patient came to us with an outside FNA diagnosis of a low-grade mucoepidermoid carcinoma. So this was the resection histomicrograph. As you can even see in the scanner power, it's a very solid looking tumor, and it looks like there's an infiltrative edge to it. And it's also reaching up to the skin. The section is cut at this level, but this tumor was ulcerating the skin. So even at this power, we can get an impression that we are dealing with a malignancy and high-grade tumor at that. So going on to higher power, we have more of an oncocytoid morphology and mostly solid, but there are these small ill-defined glands with some spaces in between. Going on to higher power, there is some nuclear pleomorphism, abundant cytoplasm, forming cells with eosinophilic granular cytoplasm. There's a lot of necrosis and apoptotic bodies, again, an indication of the high-grade morphology. And there are these kind of mucin areas, both luminal and probably intracytoplasmic. We don't see the glandular area is obvious, but we don't see any well-defined squamoid morphology. It's more intermediate and some mucinous cells. The glandular component is even more obvious in this power. It's some intracytoplasmic and luminal mucin. And we did the mucin PASD stain. It was nicely positive. So what would your diagnosis be? So our differentials were mucoepidermoid carcinoma, high grade. Oncocytic carcinoma is now doubted as an entity in the new WHO. Salivary duct carcinoma, adenocarcinoma, NOS, and last option is cannot categorize without IHC. So mucin stain is not, as we all know, is not specific for mucoepidermoid carcinoma, as it can be present in multiple tumors, especially the luminal kind of mucin is quite ubiquitous in various salivary gland adenocarcinomas. So I never sign out a case without at least doing a P63 before I call it mucoepidermoid. So this is our P63, and that was negative with a nice internal control staining. And the next marker that I'd go to was androgen receptor. Now, we can, of course, start with a wider panel, but the thing is, our patients have to pay for every IHC. So even though doing a few IHCs can have its pitfall, we generally tend to order our IHC stepwise, so 2 at a time, 2 to 3. And these patients generally have some time frame between their surgery and the next adjuvant radiotherapy. So you can take some time to work up the case instead of putting in like 10 panels on the first go and end up with an expensive proposition for the patient. So androgen receptor was nicely strongly positive, nailing the diagnosis. And we did our HER2, which was around also positive, but a little weaker. So androgen positivity rate in salivary duct carcinoma is 90%, and it's practically diagnostic of this morphology. But saying that there are case reports of AR positivity in some non-salivary duct carcinomas, and especially in carcinoma ex pleomorphic adenoma and some other differentials. So, but as far as we have seen, it's quite specific. So the other, about 43% of salivary duct carcinomas stain positive. The HER2 is another IHC, which is commonly present in salivary duct carcinomas, but it's not as sensitive as AR, only about 43% stain, and it's not specific at all, not like AR. So the other entities which stain HER2 are carcinoma ex pleomorphic adenoma, and even squamous carcinoma, adenocarcinoma NOS, mucoep, some myopithelial and epimyopithelial carcinomas have also been reported too. And this is a large meta-analysis of around 3,000 patients. Again, I guess not all of these may be correctly identified, and as you know, adenocarcinoma NOS is practically disappearing. So, but it's important to know that just on HER2 IHC, HER2 is more commonly available. You may not have AR, not all labs may have AR. You cannot stamp a diagnosis of salivary duct carcinoma doing HER2 only, but HER2 has its advantage just if it's strongly 3+ positive, or if it's 2+ positive and you've done FISH, and it's a high-grade tumor, the patient can be given trastuzumab therapy, and it has its role. So I will not talk about intraductal carcinoma, which comes in the differential of salivary duct carcinomas, and Dr. Garcia has already told us a bit about it. One entity which is important to differentiate is carcinoma ex pleomorphic adenoma. Now, we don't really differentiate as such, because one of the most common carcinomas ex pleomorphic adenoma is a salivary duct carcinoma. But there are these other entities like myopithelial carcinoma or adenocarcinoma NOS, which can arise out of pleomorphic adenoma. So it is important in the setting of mostly in the minimally invasive carcinoma ex pleomorphic adenoma, because they can have a better prognosis. So it is important that we identify that, and we also stage the carcinomas. So we have to document the extent of invasion outside the capsule of pleomorphic adenoma for these tumors. So cutoff about 6 millimeter is used. If it's more than 6 millimeter, it's known as a widely invasive carcinoma extreomorphic adenoma. And if it's less than 6 millimeter, it's known as a minimally invasive carcinoma extreomorphic adenoma, which can have a good prognosis, unless it's the myepithelial carcinoma type. Those tumors tend to be poor prognosis even when it's minimally invasive. And one useful marker is PLAG1 IHC, which helps to differentiate pleomorphic adenoma and also the carcinomas which arise X out of pleomorphic adenoma. But again, this is not a very commonly available marker. So we have to base our diagnosis on morphology and do adequate sectioning and look at the periphery of the tumor so that we don't miss this entity. Now coming to case 2, this was a 26-year-old male patient who presented with, again, a cheek swelling, and the pre-op scans showed a 7 centimeter solid cystic parotid mass with no enhancement, and we received only 3 blocks for review. So as you can see here, and I've just shared one section scanner view, the other 2 also look similar. We tend to see more of a solid pattern tumor. We don't see the cystic component. So, and this is the high power view. You can see a nerve here, a tumor comprising of solidness of intermediate cells and glandular areas, some mucinous epithelium here, going close to the nerve, but not really invading in. There's a gap between the nerve and the gland. This is showing more of infiltration in small nests. As you can see here, there's some nests, mucinous epithelium, intermediate cells, and some squamoid differentiation as well. More of the same thing, and even at this power, we can make out there's some monotony to the cells in this intermediate cell group. Higher power view, more or less not very pleomorphic, though nucleoli are prominently visible. So this is, as you can all see, is a mucoepidermoid carcinoma, and it's one of the most common salivary gland malignancies that come to us. So this is where we cannot miss or wrongly categorize, and they can be involving both the major and minor salivary glands. Now, this is very important to know for each of the tumor subtypes, whether they most commonly involve the major glands or the minor glands, because nailing down our differentials, considering differentials depend a lot on the site of involvement of the tumor. That is very helpful. And the other thing, as I mentioned previously, is the history of the extent of duration of these tumors. It's always important to go back and ask the patient if your clinician has not provided that information. One specific subtype of mucoepidermoid is the central intraosseous mucoepidermoid carcinoma, which can be seen within the mandibular or maxillary bone. As you all know, there are 3 cell types. The intermediate cell type is the most abundant, and this can have a variable pattern of expression from basaloid to large ovoid cells, and some can be very solid, and the mucinous cells can be practically non-existent, and those can be misdiagnosed as squamous cell carcinomas. So we have to be very careful, and as Munita, I think, showed a case where mammal to fish was required to send the diagnosis, and it could not be done on IHC and morphology. And these cells are P63 positive, so again, difficult to differentiate from squamous carcinoma. The other subtypes of mucoepidermoid carcinomas, as we can see, are oncocytic, sclerosing, and Warthin-like, and also clear cell carcinoma that mimics clear cell hyalinizing clear cell carcinoma. So as Dr. Garcia mentioned, that these tumors can have tumor-associated lymphoid hyperplasia with a prominent lymphoid stroma. The important thing to remember is to not misinterpret them as lymph nodal involvement, which will again tend to make us upstage or grade these tumors as higher grade. So that is important to make out. But saying that, one thing which we commonly see is that people miss reporting intraparotid node positivity. So nodes in the salivary gland can be there within the submandibular gland, the level 1B. Some can be there within the parotid. So look out for a capsule. If that node is positive, they have to be reported, as it matters in accurate staging. So the most important job of a pathologist where mucoepidermoid carcinoma is concerned, of course, is diagnosing correctly and then giving the accurate grade, because depending on that, the adjuvant treatment will be determined. Low grade has excellent prognosis and does not need any adjuvant treatment. Intermediate grade survival 5 years about 60 to 92%, and it's about debatable whether these patients need radiation. But high grade tumors have low survival, about 0 to 43%, and they do require adjuvant RT. And why these survival is varying so much from 0 to 43 is that there is no good consensus on grading of these tumors. So I don't know, I actually did a poll once of what grading system we are using both in India, and reached out to some international experts. And even today, even though grading started earlier than 1997, I think 75 or something, first grading, or 85, first grading system came about. After like half a century, there is no consensus, there's no good way of doing it. But what is common to most of the systems that they seem to identify the same histologic features as poor prognostic markers. So if you see a nice cystic tumor, so intracystic component, which does not have mitosis, does not have necrosis, lacks anaplasia, no LVI bone invasion, no infiltrative smallness, then we are good to go with a low-grade tumor. Now, coming back to the tumor that we got, we have to remember in India, frequently what happens is that there's a 7-centimeter tumor sent to an outside lab, but then they take 3 sections out of it, and you have got only the 3 sections of the solid areas of tumor, which will make you wrongly report this criteria. So take it with a pinch of salt, look at the growth. If required, pick up the phone and speak to the primary reporting pathologist before you wrongly upgrade your tumor, because the cystic component was not sampled and not sent to you for review. Next is AFIP, as you can see here, tends to downgrade the tumor, whereas the Brandwein grading system has more parameters and it tends to upgrade the same tumor. So there is very little consensus between the two systems, but these two are the most commonly used, and there is no really good or bad. When correlated with survival, each of these grading systems have shown an equally good outcome, even if they don't match with each other. So I have no preferred thing, but I generally tend to do Brandwein, but I see the whole overall picture, and then I have a discussion. We take all our tumors through the MDT, and if there is any discrepancy or any doubt, that is discussed with the clinician before the treatment decisions are made. One thing to note here is that anaplasia gets a score of 4 in AFIP, whereas it gets pronounced nuclear atypia gets a score of 2. And there is no good definition for anaplasia or nuclear atypia. And when you're seeing these tumors rarely, like once a month or something, it's very difficult to use this criteria because it can be quite subjective, what looks anaplastic to you. And when you see a lot of squamous differentiation, they have big cells, they have prominent nuclei. What looks anaplastic to you might not look to your colleague. So push on this when depending on your other criteria. Otherwise, don't jump to upgrade a tumor just on your assessment of anaplasia. This is one caveat which I feel that mistake people make. The modified Healy grading system was proposed by the MD Anderson group. Again, it's some people use it, but it's very complicated. I don't think in India it's that popular. So as I've mentioned, these are the caveats of the AFIP and Brandwein systems, and there is lack of consensus, which makes many of the international experts actually use their own intuitive grading system. What the MSKCC group did was they reviewed all their cases, and they what they found that mitosis and tumor necrosis are pretty objective reporting criteria. They have less subjectivity, and they were consistently present in the tumors which were behaving very poorly. So mitosis more than equal to 4 per 10 high power fields, and presence of necrosis. So their grading system, they mainly gave weightage to these two parameters, whereas infiltrative margins and a solid growth pattern, lack of cystic morphology, was also given weightage to. So using those as these survival curves show that necrosis and mitosis were the most significant markers which led to the grading system. So coming back to our tumor, sorry, we had, even though the cystic component was low, and there, in some areas it looked like there was invasiveness, when we go back to the scanner, most of the tumors seem to be within a well-circumscribed area. All the infiltration was actually within that circumscribed area and not outside the tumor capsule and not outside the salivary gland capsule. So we downgraded this tumor to an intermediate grade, avoiding adjuvant treatment. So the take-home message from this is that P63 positivity is important to assess before categorizing a tumor as microepidermoid carcinoma. High-grade carcinomas are rare, as shown by the MSKCC review. They should be around 6%, and we should take care before overgrading mucoepidermoid carcinomas. In their review, they found actually 28% cases were misdiagnosed as mucoepidermoid in MSKCC review, which stresses on the point that how important use of IHC is, how there's subjectivity to diagnosing salivary gland tumors, and we have to take care, and grading salivary gland tumors, and take the overall picture before we make a diagnosis. The CRT-C1 mammal 2 analysis helps to confirm the diagnosis, and especially if you have a case where the differential could be a benign tumor in a very well circumscribed small introductory tumor which is mimicking mucoepidermoid. In those situations, I think it is useful to go that extra length, have an MOU with a center like TMH Mumbai, which has this test, and confirm before giving somebody a diagnosis of malignancy. Now, case 3, we had a female patient from Bhutan with a right cheek lesion with pain and itching, and the CT scan showed multiple parotid nodules and enlarged right neck nodes. This was again a solid tumor. Somewhat intermediate to squamoid morphology, lot of necrosis, high grade, and P63 positive. Again, the same list of differentials as the prior case came in, but something that led us to suspicion up was the presence of this strong lymphoid, heavy lymphoid stroma. And also the patient came from Bhutan, and we seem to see a lot of these endemic patients coming from the Northeast who have EBV related tumors. So this was EBV strong positive and a lymphoepithelial carcinoma. So based on the morphology and the demographic history of the patient, we could jump to EBV as the first line and not waste other markers. Case 4, this was a 35-year-old female who presented with a 4-centimeter mass on the right side of palate and extending to the maxilla, pterygoid plate, eroding the base of maxillary sinus and nasal cavity, then extension to lower alveolus. So even from this history, we know we are dealing with a high tumor. And this is the morphology. very solid looking tumor comprising of small cells in small nests. And this is the overlying epithelium. Even though the tumor was widely infiltrating, the cells seem to be monomorphic, and there is no dysplasia in this overlying epithelium here. And the tumor is in nests with some eosinophilic desmoplastic stroma in between. And there's a salivary gland tissue on the side, and a minor salivary gland tissue, lymphoid and sclerosed stroma, which is common in lymphoid reaction, and then this tumor in nest with somewhat of a monomorphism, which is more appreciable at this high power. The cells have eosinophilic pale granular cytoplasm and strongly p63 positive in this IHC field. You can see more prominent stroma with lymphoid reaction. So even though that this tumor was quite aggressive on presentation on radiology, there was a monomorphic morphology, no keratinization, lack of surface dysplasia, which raised our suspicion, and we went back and asked the clinician to provide history. And then we found out that the patient had a soft palate lesion 12 years back, which was operated previously. So this is a re-resection and in an outside hospital, and it was called myopithelioma. So we did the myopithelial markers, which were negative, but this patient was CK7 positive, and the tumor was CK7 positive and p63 positive. And we did not do p16, but some of these tumors can be p16 positive, which also adds to the misclassification of these tumors as non-keratinizing squamous cell carcinoma. So this, as you've seen examples in the two prior talks, this is hyalinizing clear cell carcinoma, and we were lucky enough to be able to confirm this with FISH using an AWSR1 breakapart probe. But even without the FISH support, what helps is the monomorphic nature. They're generally more indolent. They will give you a longer history or like a slow growth. And the desmoplastic hyalinized stroma is the telltale sign, along with the monomorphism of the squamous nest, lack of good squamous differentiation. And another caveat is some of these tumors can have glandular appearance, which can lead to misdiagnosis as leukoepidermoid carcinoma. So we have to be aware of that. Now, case 5 is a 40-year-old female who presented with a left submandibular swelling for 3 months. And this came with an FNA report of a basaloid neoplasm. So it wasn't categorized any further as benign or malignant, which is often the situation that it is cellularity is poor, and the pathologist cannot tell between, and there's a long list of differentials of basaloid neoplasms, from like pleomorphic adenoma where the stromal component is low, to a basal cell adenoma, basal cell adenocarcinoma, adenoid carcinoma, where the cribriform telltale punched out spaces are not prominent. So these long list of differentials sometimes limit us from categorizing between benign and malignant. And USG was done for this patient, and she had a 3 centimeter swelling with multiple enlarged nodes. So even in the scanner power, we can make out predominantly a solid kind of morphology, and here the tumor is reaching the margin of resection, and it has an infiltrative morphology, mostly nests of basaloid cells, solid nests, and some glandular patterns. There's a hint of cribriforming here, but not the classical punched out kind of cribriform spaces, and a little bit of tubular component as well, some basophilic material in deposition around the nest. And the solidness also had somewhat of a palisading at the edge of the cell. Perineural invasion was quite prominent in this tumor, margin positive, and higher power showed quite prominent mitotic figures. As you can see here, you can see about 3 in this field. There is quite a significant degree of nuclear pleomorphism and foci of comedonecrosis within the solidness. So we did P63 IHC, and focally it did show some retained myoepithelial cells, but large areas of the tumor was negative for P63, as is often the case in high-grade adenoid-cystic carcinomas. The other IHCs we did was calponin was negative, beta-catenin was negative, showing this kind of cytoplasmic staining. So our differentials here were between adenoid-cystic and basal cell adenocarcinoma. So adenoid-cystic is a biphasic tumor where the luminal component is identified by CK7 and c-KIT, and the abluminal with the myoepithelial markers. But when we have a more solid presenting tumor, then the IHCs are not as helpful as in this case, because P63 only had in one corner of the tumor. I could not share a scanner view of the whole IHC slide. Largely it was negative, and only one corner there was some retained cells. So, and then there were these basal palisading of the cells, which tend to point towards basal cell adenocarcinoma rather than adenoid-cystic as the differential. Adenoid-cystic carcinoma is a poor biology tumor. They all ultimately behave badly, but grading is important for prognostication. And that is done on the extent of the solid tumor. So more than 30% is high-grade tumor, and between 1 and 30% solid area component is intermediate grade. So MIB IHC or MIB translocation, if you have access to that, helps to nail the diagnosis, but it's only present in 65% cases. But we did not have that. So our differential had to be on the basis of morphology and IHC. So basal cell adenocarcinoma, the main point to remember is that generally it's a low-grade, low-risk tumor. So in our case, we had very clearly a very high-grade tumor. There's comedonecrosis, there is a lot of mitosis, and it is behaving poorly because margin is involved very clearly. So the presentation was more of a high-grade tumor, which was taking us away from basal cell adenocarcinoma. And another soft criteria is that basal cell adenocarcinomas are more commonly seen in the large gland, whereas adenoid-cystic is more common in minor salivary gland presentation. So now, after stamping adenoid-cystic, now we were left with, is this a solid adenoid-cystic, or is it an adenoid-cystic with high-grade transformation? Because depending on that also, the prognosis changes widely. And so that differentiation is made on the nuclear prominence and the degree of anaplasia, the presence of desmoplastic stroma, the presence of mitosis more than 10 per high power field, Ki67 can be used to differentiate using a cutoff of 50%, extensive comedonecrosis, and absence of abluminal layer. So because of presence of these features, we indicated that this was a high-grade transformation rather than just a grade 3 adenoid-cystic carcinoma. And as you can see here, this paper by Sitala et al., the pleomorphism is quite significantly obvious in the high-grade transformation as compared to the solid adenoid-cystic carcinomas. And on follow-up, our patient very soon presented with multiple pulmonary metastasis with progression of the tumor, as is expected in these dedifferentiated high-grade transformed tumors. So the take-home message is that dual cell differentiation helps us stamp a diagnosis of adenoid-cystic carcinoma. high-grade transformation should be differentiated from solid pattern, and basal cell adenocarcinoma is less aggressive, and it is important that we don't misdiagnose these cases as a low-grade tumor just on the basis of peripheral palisading, as IHC doesn't really help in that situation. It's just morphology, especially when you don't have access to molecular. Case 6 is a 69-year-old male with an oral cavity hard palate growth for 1 month. And this is a tumor with a kind of tubular cribriform kind of morphology present in multiple nodules. There's some cystic spaces with cribriform pattern, and on higher power, tubular and cribriform morphology with very bland looking tumor cells, more trabecular kind of presentation here, very monomorphic, small nucleoli, pale chromatin, and this tumor was positive for S100, SOX10, and P63, while P40 was negative. So this was a polymorphous adenocarcinoma. This low grade has been removed in the current classifications because it was recognized that many of these tumors don't really behave as indolently as thought before. But one important thing to remember that they were called low grade because they look low grade most of the time. And very commonly, pleomorphic adenomas come in the differential of polymorphous adenocarcinomas. So one is benign and one can behave like an aggressive, not so indolent malignancy. So that differentiation is very important, and both are two cell type of tumors. So using IHC does not always help except P40. So P40 will be retained in pleomorphic adenomas in the myopathilar component, whereas it is lost in polymorphous adenocarcinoma. So that's very helpful. And the other thing is the presentation. So minor salivary gland origin, hard palate location, infiltrative edge, those will point towards polymorphous adenocarcinoma, whereas pleomorphic adenoma will have an overall sense of, even if it sends pseudopods, even if there are multiple nodules, it will have an overall sense of lobulated, well circumscribed nature of tumor, and more common in the large glands. And PRKD mutation helps to diagnose. So I've already mentioned this, that P40 negativity in presence of S100 positive tumor helps to stamp the diagnosis of a polymorphous adenocarcinoma. Case 7 was a 12-year-old boy who presented with a round form swelling on the right cheek for 2 years. And FNA came as salivary gland of uncertain malignant potential, and this is a solid, very well circumscribed looking tumor with some infiltration over here, a pink tumor, solid pattern, and the cells seem to have this foamy, tubaculated cytoplasm, and the nuclear has some variable pleomorphism, but mostly pale with prominent nucleoli, no mitotic figures visible, granular cytoplasm with some hobnailing over here. And our differentials in this low-grade neoplasm with a solid pattern was actinic, secretory, and polymorphous adenocarcinoma. So polymorphous, again, because of the name, it is polymorphous, so they won't always look basal, and it is important to keep it in mind for as a differential in multiple low-grade neoplasms. So the first panel we used was P63, S100, CK7, and DOG1. And this tumor was positive for CK7, S100, SOX10, GATA3, MUC4 as shown here. GATA3 was a bit weak and patchy, and it was negative for DOG1, P63, and P40. So we could stamp a diagnosis of salivary gland carcinoma. It was earlier called MASC and identified with this specific fusion of EDV6 and NTRK. But in the 2017 classification, the name was changed to secretory carcinomas because they showed similarity to that of breast. These are indolent tumors, and the importance to differentiate, and they really mimic acidic cell carcinomas on morphology, except two features. One is the presence of zymogen granules are absent, even though on H&E they can show very granular foamy kind of cytoplasm. And they have this specific fusion and can be amenable to TRK inhibitor therapy if we have access. So that and the IHC features are quite specific. So S100 and GATA3 mammoglobin positivity is secretory carcinoma, whereas S100 negative DOG1 positivity leads to acidic cell carcinomas. But not all cases will be classical. So there are those cases where we cannot differentiate, where using this fish can be useful, especially for an affording patient who can get the inhibitor therapy. But for most cases, if we cannot stamp and we can put it in this general group of tumors, it is still okay for management of the patient. And this is an example of a typical acinar cell carcinoma, where the zymogen granules are quite prominent on the PASD stain, which helps to confirm. And these are the variable subtypes of acinar cell carcinoma that we can see, so which widens our differentials when we are trying to diagnose this tumor. And DOG1 positivity really helps to nail down the diagnosis. There's a newer antibody called NR4A3, which helps to confirm acidic cell carcinoma. Is supposed to be very specific and sensitive, but we of course don't have access to it. And again, like mucopurulins, acidic cell carcinomas can have a prominent lymphoid background, and that should not be confused with nodal metastasis. And some of these tumors, like all other salivary gland tumors, can have high-grade transformation. So just stamping a diagnosis is not enough. It is important that for all these cases, we do adequate sectioning. We look at all the tumor sections to look out for focal high-grade transformation, so that if that is missed, we will be wrongly stamping a high-grade tumor as low-grade and denying these patients of adjuvant treatment. So take home from this group of tumors is acidic cell carcinomas are rare outside the parotid. Both acidic and secretory are indolent tumors, but secretory carcinomas can be amenable to the anti-TRK therapy. So it's important to diagnose them accurately, and usually a combination of using the PASD for zymogen granules and a SOX S100 and DOG1 combination helps us to nail this diagnosis. For lack of time, I'm not going to touch upon the newer entities, and Dr. Garcia has also already nicely told us about microsecretory adenocarcinomas. Sclerosing microcystic adenocarcinoma can be a challenge, especially in the differential of polymorphous adenocarcinomas or adenoid-cystic carcinomas. But these tumors have this presence of CK7 and P40. They are biphasic in nature, so sometimes IHC can help. They are always of minor salivary gland origin. I'm yet to encounter a case, so I have no experience with this. And I'll end with the last case, which is a 28-year-old female with soft tissue right side mandibular gland swelling for 2 years. And CT scan showed this tumor, which was well circumscribed on growth as on microscopy, as you can see. And very nice, well circumscribed separated from the salivary gland tissue. The cells are bland and quite spindly, giving a differential. We were thinking of this myopithelial carcinoma. And again, very monomorphic, bland kind of cells, no mitotic figures, and this prominent vascular pattern. Bland cells on high power. And we did P63 and CK7 and S100, all three were negative. And CD34 was positive, so was STAT6. So this was a solitary fibrous tumor, a rare mesenchymal tumor. So we have to sometimes think out of the box. Metastatic tumors are common in salivary gland location. Soft tissue tumors, Dr. Munita has also shown a big range of lymphomas, vascular tumors, adamantium like PNETs, all possible entities are possible in salivary gland locations. So before, and sometimes IHC can play tricks. So before we jump to a salivary gland differential, it is important to think of other options and rule out metastasis or non-salivary origin tumors. So the take-home message of the summary of IHC approach is the site, the morphology, the long-standing history, everything is important before we jump to do IHC to categorize these tumors. A good approach is to differentiate basal versus non-basal, one cell versus dual cell population, and using the initial panel. And the helpful markers are the ductal lineage ones, myepithelial, and we don't have to do all of them. Just pick one as the first line. If P63 is retained, like in polymorphous adenocarcinoma, then put in the P40 to look for lots. S100 positive tumors are the myepithelial, secretory, and polymorphous adenocarcinomas, whereas the negative ones are salivary duct, mucoep, and clear cell carcinomas. DOG1 is quite very useful for cynic cell carcinoma diagnosis, AR for salivary duct. HER2 is sometimes helpful, and Ki67, I'm not a big fan of using it, but it has its role. So thank you and happy Republic Day to all of you.
Thank you, Dr. Paromita, for that enlightening talk. You've given us much practical advice that we can use in our day-to-day reporting. And I think you've covered the wide spectrum of salivary tumors, both with your cases and with a short description of the new entities. And it's comforting to know that actually morphology is still the mainstay of diagnosis in salivary gland. I think you've shown us that with a small panel of IHC, we can come to a fairly definitive diagnosis in most of the cases.
So as I said, that more than the patient paying for it, sometimes the clinician doesn't want to pay for it because they'll end up telling you that I'm not going to do anything different. So then why will I do this? So keeping that in mind, knowing the pathway that your patient will follow, you need to know where you need to push for it, where you need to spend that money and send it to an outside center to test, and where it is okay to let go with the differentials.
We'll go to the questions. I think I didn't see any questions for this session. I'll just check the chat.
No, I don't see any questions.
No, ma'am, there's no, I didn't see any questions in chat box either.
Okay. Then shall we, Rajan sir?
Q&A, anything there? Q&A?
No, sir, not for this session.
Rajan sir, if I may, I had posted one query in the chat box. Paromita, Dr. Anla here. Yeah, so you were extensively discussing about the different grading systems of the mucoepidermoid. So is it really recommended by the WHO, or can we just stick on to the basics like more cystic and more solid? Like if it is more cystic, literally it is going to be a low grade, and the higher grades will generally have all those features, considering the fact that high grade mucoepidermoid carcinomas are really rare. So what I have heard from the experts on this area is like you don't use these A5P brandwin because of the difference in these grading systems on serving as a prognosis, because they themselves have a disparity among themselves, the A5P and the brandwin.
Right. So no, all of them are validated to have prognostic significance. That it does, but then they have no consensus amongst themselves. So you have to have a clear understanding with your clinician as to what they are going to be using as for treatment. So we do use brandwine, but then we don't upstage using. We use it with that understanding that look at the overall field. So yes, if it's overall well circumscribed, overall cystic, then cystic tumors are not a cause for worry. You have more than 25, they come into low grade for everybody. It's those intermediate zone tumors which end up going to high grade when you're using brandwine. So that is where you have to go by the overall feel, how much of sectioning it has been done. Because you don't want to hear in India, if you leave a patient, they don't come back for follow-up. So you don't want to have your case recurring. And at the same time, the side effects are too much. So you don't want to over-radiate. And as you rightly pointed out, high-grade tumors are very rare. So before we overcall something as high-grade, we have to be a bit aware that it is significantly invasive enough. And as I like the NSKCC system, so necrosis and mitosis is actually where
that is more
only situation where
more
they
practically
call high-grade.
applicable, no? The MSKCs.
Without those, they generally avoid calling high-grade.
Yes. And one more query is like in hyalinizing clear cell, have you come across, like in the literature at least, whether the fish can be negative?
Yes, of course, fish can be negative, and the other caveat is also there. Some of these genes are in overlapping with other markers, so they are in a so there can be a wrongly false positive interpretation as well, because the partner or the neighboring gene is mutated, and that is playing a role. So yeah, with the EWS break apart, there are those caveats, because none of us are doing PCR for exact typing. So yeah, so those issues are there. But the thing is that, you know, what are you achieving? Again, at the end of the day, that no adjuvant treatment by miscategorizing them as squamous carcinoma. So there, if you paid attention to the monomorphism and you know, the adjacent salivary, minor salivary gland location, you see some salivary gland parenchyma around it, long-standing tumors. It's usually possible.
Yeah, thank you. Thank you.
Correctly.
So if there are no more questions,
I have,
I think
ma'am, two people have raised their hand, so I've allowed them to speak. Dr. Meena and Dr. Nikita, do you have any queries? Right. Okay, I think it might be by mistake or something.
maybe. Any more questions?
I think.
Okay. So on behalf of Kerala IAPM Chapter, thank you once again, Dr. Paromita, for that superb talk. And I also take this opportunity to thank Rajan sir, Dr. Ani, Dr. Anila, and the Mindray team for organizing such a comprehensive webinar on head and neck pathology. It's really been useful for all of us, both consultants as well as pathologists. And I think you've given us enough tips and tricks and pearls that, like my Bani said yesterday, I think we'll be able to crack the next case we get on head and neck. Thank you so much. Over to Rajan sir and Ani for concluding remarks.
Thank you very much.
Hello, Paromita. Thank you for the wonderful session. Even you have some throat problems, you actually you made it, right? Okay.
Yeah. Thank you so much.
Okay, it was a wonderful session covering all the salivary gland issues, and that too in a resourceless atmosphere. Okay, so thank you very much. And now it is the end of this 2-day webinar, and Annie, for the for the vote of thanks.
Yes, sir. Okay, respected teachers, seniors, colleagues, and dear postgraduates. It is my pleasure to deliver the vote of thanks for this occasion. I, on behalf of IAPM Kerala, would like to extend my sincere gratitude to the distinguished speaker, Dr. Joaquín Garcia, a surgical and molecular pathologist at Mayo Clinic, Rochester, Minnesota, USA, Dr. Shubhata Kane, former professor in HOD Department of Pathology, Tata Memorial Hospital, Mumbai, Dr. Anjal Kakar, associate professor, Department of Pathology, AIMS, Delhi, Dr. Munita Bal, Professor, Department of Pathology, Tata Memorial Hospital, Mumbai, and Dr. Paromita Roy, Senior Consultant, Department of Pathology, Tata Medical Center, Kolkata, who have been with us for the past 2 days, sharing their experience and enlightening us. I also like to take this opportunity to thank our esteemed moderators, Dr. Shankar Sir, Anila Madam, Dr. Smita, Dr. Lada Abraham, and Dr. Shalini Kuruvilla. Anila Madam deserves a special recognition because her unwavering support served as a foundation for the webinar. Additionally, I want to thank the Mindray India team for giving us access to this platform. They have been with us every step of the way, without whom this cannot succeed. Mr. Nikhil and Ms. Shama and the entire technical team, thank you. And last but not the least, the chapter would like to express its sincere gratitude to all its members, consultant pathologists and postgraduates across the nation who contributed to the success of this event. We will end the session with the national anthem. Ms. Shama.
जनगणमन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you very much. And the fourth webinar of IAPM is actually comes to an end. Okay, that's enough. Good night, everybody.
Good night, sir. Good night, everyone.
Good night, all.
Thank you.
Good night. Good night. Thank you.
Thank you.
Thank
Nisha.
you.
Emma?
Yes, sir. Yes, sir. Should I end?
Yeah.
Okay,
Big thanks to you.
Thank you, sir. Thank you so
Yeah.
much.
Okay. Nikhil is there?
No, Nikhil is not there.
Okay.
So
Right.
he had some emergency, so then he went.
Okay.
Thank you,
Dr.
sir.
Garcia
Thank
is
you.
still there, I think.
Yeah.
Gracias. Oh.
Okay,
Then I shall end, Dr. Annie. Thank you.
Yes. You
Yeah.
can end.
Yeah.
Bye. Good night.
Bye-bye.